That's not good.
Hi, Tom.
Kittitas County Public Hospital District Number 1, Board of Commissioners regular meeting dated May 28th, 2020. Welcome to everybody. Welcome to our visitors that are here with us today. I had asked Mandy Weed if she could do a roll call.
Bob Davis.
Here.
Erica Libanow.
Here.
Matt Altman.
Here.
John Ward.
Here.
Terry Clark.
Present and accounted for.
Julie Peterson.
Here.
Dr. Kevin Martin.
Here.
Scott Olander.
Here.
Mandy Olson.
Here.
Vicki Machero.
I'm here. I'm here.
Thank you. Rhonda Holden.
Here.
Carrie Barr.
Here.
Amanda Scott.
Here.
Michelle Whirl.
Here.
Lisa Potter.
Here.
Jason Adler. And then it looks like we also have Shelby Hageman and Tom Dingus on the line. And if there's anyone else that's on there, if you could let me know, please.
Kelly Goody in Dallas.
Thank you.
Great, thank you. Thanks, Mandy.
You're welcome.
Yeah, congratulations to everybody on, which we'll talk about more later, on reaching phase 2. So that's exciting times, and hopefully the last time we'll be doing this, but we'll talk about that more later. Our first item is the approval of the agenda, or if there are any items that need to be pulled from the consent agenda.
This is John. I'll move to approve the agenda.
John approves.
Second, Erica.
By Erica. All in favor, say aye.
Aye.
Any opposed? Okay, thank you. Consent agenda, which in that we have the minutes of the board meeting of April 23rd, approval of checks and the foundation report and finance committee. Can we have a motion to accept the consent agenda?
And I move to approve. Matt.
Second.
Terry, second. Or Erica can second it. You beat me.
Terry's got it. We're good. Thank you.
Okay, Terry second it. All in favor, say aye.
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 Any
Aye.
opposed? Thank you. So our first off, as far as presentations, we get to hear from our audit person, Tom. Tom, welcome.
Hello, everyone.
Do you want to take off on our audit report?
I will do that. I'm going to share screen, but I have a PowerPoint presentation here.
So for the board's information, John and I sat through this on Tuesday morning for most of it. So, but look forward to hearing from Tom again.
All right. Hello, everyone. This is Tom Dingus from Dingus Aircorn Associates, and we're the CPA firm that performed the audit for the district for several years now. And like I said, we gave the presentation on Tuesday morning to the finance committee as well. That was more in depth than planning to do tonight, but certainly ask questions if I happen to maybe skip over something you had a question about. But we did go in more. We'll have gone into more in depth on Tuesday morning than I'm planning to do right now. But certainly, don't let me skip through anything you wanna hear about. So first of all, get going here on my PowerPoint. Can everybody see the screen? the power something on the screen? Yep. All right. All right. So just quick, I think most of you know or been commissioners in previous years or I've been in other meetings, but who we are as Dingus Aircorn Associates or DZA, a CPA firm. We're located in Spokane Valley, Washington. We work with rural, 95% of what we do is healthcare all over the Western United States. Most of what we do is with critical access hospitals and rural healthcare. About 40 people in our firm and about 3 other partners. We work with over half of the public hospital districts and critical access hospitals in the state of Washington. So just a quick little there. The agenda for this evening is going to go over the audited financial statements, the audit reports, and kind of a brief overview of the key points in the financial statements, and then the financial indicators or the graphs and ratios that I think you've all seen before as well that show comparisons. The agenda right there talks about a required communication with those charged with governance. I did cover that with the finance committee, so there's nothing in it of any real significance. So we'll kind of skip through that part tonight. So going into the financial statements, kind of just hitting some really high points is on pages. What I'll also do is I'll tell you what page I'm on in the financial statements if you wanted to follow along with those as well. But following along in just the PowerPoint will work as well. So on pages 1 and 2 is the first of the 2 auditors' reports. This is the one on our report on the financial statements. It is an unmodified opinion, which means that the financial statements that follow present fairly the financial position changes in financial position and cash flows of the district, what you wanted to say, what you expected to say. So it is the right report you want to get. There is kind of sprinkled through the financial statements a couple places where the COVID-19 pandemic is brought up in the audit report. It is something that happened subsequent to year end, but it is obviously significant why we're all meeting this way and impacts on your operations. And so there is an emphasis of matter in the auditor's report as whether there is the financial uncertainty it caused, and then addressing that and your plan to address it, and then just the fact that it is a significant subsequent event to a reader of the financial statement. It's also covered in a note later in the financial statements. The pages 3 through 8 are management's discussion and analysis. Prepared by management, it's condensed financial statements. It's the narrative that goes with the financial statements that can essentially kind of tells the story that goes with the numbers. It's a good reference for if you just wanted to go back to the financial statements at a later date and just kind of get the highlights of what happened. It's a good starting point. Page 9 is the asset part of the balance sheet. We'll come back to the financial indicators part of this, the cash and cash equivalents when we get to the financial indicators and graphs part of the report. Probably the most significant thing you'll see is in the current assets. Last year there was on the third line down, there was almost a $1.9 million receivable estimated third-party payer settlement from Medicare. There's no receivable this year, and actually when we go to the next slide, you'll see there's a payable. That is just the normal ebb and flow of, a little bit bigger numbers in each year, but kind of the ebb and flow of how critical access hospitals are reimbursed for Medicare services, and inpatient, outpatient, and rural health clinics is that you paid on an interim rate. So there's always some true up between what you got paid and the actual cost after the end of the year. So receivables, payables, not necessarily a good or bad thing in either direction. That's the main thing there. Other than, I guess, actually the fifth line up from the bottom, cash and cash equivalents restricted for capital acquisitions. That $5.6 billion is your remaining bond funds, proceeds from your last bond issuance that's available for capital expenditures. Liabilities and net position. Only real significant thing here is what I mentioned earlier. In the estimated third-party payers, there's the payable of $1.7 million. A little bit of that is Medicare. The biggest chunk of that is pretty much what was there last year was the payable, estimated payable to the state of Washington for rural health clinic, Medicaid managed care reconciliations. There is legislation that the state passed where that amount should be forgiven, but it's not an official, the legislation is passed, but you haven't officially got your notice yet. And so it's still not like written off essentially or forgiven as a liability yet. And then also just with some uncertainties, obviously with budget scenarios and everything, and until you really 100% know you don't owe that money, it'll still show as a liability. So would expect that to be forgiven in 2020. Operating results, the key things here, net patient service revenue up 6%. That's going to general volume increases across most of the services, and particularly your clinics, revenue cycle improvements that went on within your finance and business office team. So a 6% increase in net patient service revenue. And also when you get down to, compared to the operating expenses, your salaries and wages went up 4%, and overall total operating expenses went up 6%. That's why where you see that increase of your operating income of $1.25 million last year to almost $3.5 million operating income this year. And when we get to the financial indicators, you'll kind of see that the relationship, but a very positive trend there from a solid operating income to a very even better operating income. And the bottom part of page 11 is the non-operating results, and the key number here is the second line down, the taxation for debt service is there is no longer the unlimited tax general obligation levy being collected because the bond related to that was paid off in 2018. And so that no longer is collected. And the third line up from the bottom, the change in net position, just about $3.7 million positive net income compared to the $2.5 million of the previous year. And so a significant increase, even with that $1.4 million less tax revenue in 2019 compared to 2018. So all very positive trends. And like I said on Tuesday morning, these are the easy kind of reports to give, when financial results are good and cash position is good and there's no findings. And that's, if you wanted like a really short version of this report, that's what I could have said. Everything's all good. But it needs to be longer. So we'll go a little longer.
Tom, real quickly, what
Yes.
was the percentage increase in operating expenses year over year?
4%. Total was 3%.
Okay,
While salaries and wages.
I thought you said 6%, and I just wanted to highlight for the board really that cost containment.
Yeah. It's possible I was looking at 3 and said 6, so I meant to say 3%. Yeah, and that was actually the point I was trying to get at it too, is that the revenue went up more than the expenses went up. Yeah, which is a good thing. The next page is the statement of cash flows. And I don't always talk about this, but it is interesting to see that the first subtotal in the first section is last year operating cash operations used up $5.9 million of cash. And this year it's a positive 7.8. And that was last year was the impact of the Cerner implementation with the patient accounts receivable system, as your patient accounts receivable collections were slower. And now they're at a more steady pace, and that's back the way you would normally expect to see it. The notes to the financial statement start on page 14 and go through page 31. Not going to hit these in any great detail, but I do think they're important as you look at the financial statement, with the 3 primary purposes being they explain who you are, which that's pretty straightforward. But then the summary of significant accounting policies goes through how different account balances and transactions are recognized and reported in the financial statements. Real good reading to understand the financial statements. But my best joke I got is that it's not so good though you want me to read it to you or spend a lot of time on it. So do look at it. And then other notes on significant account balances and transactions that you would want to, further information on when you're looking at a financial statement. The keynotes, upcoming accounting pronouncements, what's most key about this is this has been in here for several years, and it was finally going to be the year in 2020 when when leases were going to be accounted for and reported differently on the financial statement. Yeah. Uh-oh. No. And so, but because of COVID-19, actually, all accounting standards and auditing standards have been delayed. And so what was going to go into effect in 2020 is now pushed out to 2022. Oh, long-term debt on note 5, not much to point out there that's real different there, other than the unlimited tax general obligation bonds are no longer outstanding. Note 7 is the net patient service revenue. The takeaway from that is that your revenue by payer, Medicare is about 37% of your business, and Medicaid is 15% of your business. So just a little over half of everything you do is Medicare and Medicaid, which as a critical access hospital and a rural hospital is on the lower end of the scale. A lot of times you'll see that more in the 60s and 70% range, and sometimes even 80% for some critical access hospitals. And then note 12 is additional information about the subsequent event information, going concern information, and your plans to, and how COVID-19 has been addressed. Additional information on that so the reader's aware of that really financial uncertainty that creates. It lists out what had been received, like from the CARES Act money of nearly $6 million that has been received subsequent to year end. It talks about how Medicare sequestration has been suspended for the rest of the calendar year, which is a 2% reduction in all your Medicare payments. So getting that 2% back actually has some significance. It's kind of a lot of times forgotten in all of this.
Is that just for the 2020?
It's just 2020. It was it gets reinstated at the end of 2020 on January 1, 2021. And interestingly enough, just for it extends, it's tacked on to the end of the regular sequestration period. So years from now, we'll still be going on it. That extra 9 months or 10 months or whatever they add.
Yeah.
So yeah. Gonna assume we're not going to balance the national budget anytime soon. Not go away. We didn't make it any easier this year. And then, and this is obviously an evolving, there's other, some organizations requested Medicare accelerated payments and essentially a short-term loan of getting the money in advance. There's the payroll protection program loan that's available that you guys have considered, just didn't have it by the end of this. Other ways to address this. It
Tom,
creates
sorry.
a lot of interesting. Oh, go ahead. Somebody had a question.
Sorry to interrupt. I don't know if this is a question for you or Scott, but just to go back to note 7 and the payer mix, I understand what you're saying, and I've always heard that we have a pretty decent payer mix. Don't rely as much, maybe as some places, on Medicare and Medicaid, especially because of all the state employees with the university in town and stuff like that. But I just want to get my mind around the percentages. So could you just sort of repeat or explain what you said about the percentage of our revenue from Medicare and Medicaid?
From Medicare, the net revenue you receive is about 37% of your total revenue. And then Medicaid is 15%. Both of those numbers, the Medicare number includes your Medicare Advantage revenue as well, and the Medicaid is both your traditional Medicaid, and it's actually mostly the Apple Health or the Medicaid Managed Care as well, because that's what most people get their Medicaid coverage through. So
and you said that typically that's higher, you said, at a lot of other hospitals?
Yeah, I mean, every critical access hospital, every rural hospital is different, but you're definitely on the lower end of what we see in the Medicare and Medicaid. And a lot of it's what you just said, the different employer mixes in the community demographics. And when we get to the financial indicator graphs too, you'll see that your bad debt and your financial assistance, charity care numbers are low, not like lower than most. So yeah, it all does point to that you have a lot of commercial insurance payers, which are generally the better insurance payers. So
Okay.
it does give
Thank you. Thanks.
And then, so Tom, on the PPP, are other critical access hospitals participating? Are most critical access hospitals participating in that?
Definitely some. I don't have that's interesting. Actually, Scott and I talked about that a little bit today, and then I've talked to other people, but quite a few have. Not everyone has taken advantage of the PPP loan. All of this is tricky in that how all of these programs and all this legislation is not as tightly written as, because it was an urgent deal. And so at this point, most of the hospitals we work with and most of the other healthcare organizations have, between the payroll protection program loans, the CARES Act money, feel like they have more money than they've lost in revenue or had direct expenses at this point. So now the concern is more about capturing all the expenses and calculating the lost revenue and making sure you keep all of that CARES Act money. So for payroll protection loan, initially it was uncertain whether the public hospital districts that didn't have the dual 501c3 not-for-profit status could actually access the loan. So some governmental hospitals were a little later to accessing it than others. But I don't know if it's half and half, but some have, some haven't.
Bob, of the hospitals that I participate with the Rural Health Collaborative, three of the hospitals as of a month ago had received paycheck protection loans, and the others had not yet.
I mean, even as using it as a loan only versus forgiveness is a pretty reasonable way to have access to some money.
Yeah, and that's actually a little bit of the conversation Scott and I had today. Is like, even if you don't think or intend for it to be forgiven, it still gives you some more flexibility. Yeah. Because, one thing, when I talked with my partner, Shar Schaefer, and we talked about this, is we do need to remember that, things are getting better right now, but we might need this money later. Right. If we go forward in the phases and then go backward in the phases, and we have lost revenue again. Right now, I think we all feel good and confident, but Scott might not be the case in 2 weeks or 2 months.
Program that Scott and I were talking about today was the accelerated payment program that a number of the hospitals I know participated in, the PIP program, which initially we looked at and waived off because the interest rate it was entirely on the front end assumed to have been just an advanced payment program, and if you didn't have the cash to pay it back when it was due, the interest rate was like 10.25 or something.
Oh.
Now there is some talk about forgiving those advanced payments. So I'm watching that amounts to us not taking advantage of what could end up being a windfall or part of the cash that hospitals are going to be using to keep themselves whole. So we'll watch how that legislation advances.
Yeah, there's been lobbying for that, and anything's possible, but that, to me, seems a little more on the unlikely side, just because it wouldn't be equitable to the hospitals that didn't take those advances, because it's a huge number. I don't know if you guys calculated it, but it would have been the biggest number it would have dwarfed all the rest of this. Right. And generally, our advisement to everyone is it's all the money you get, either recorded as a loan or deferred revenue, like a grant, and recognize it as revenue as you have the qualifying expenses or the lost revenue, on the assumption that when it's all said and done, you're not expected to come out with a windfall on this. It's supposed to make you whole. So if you get overpaid, it might go back. We talked about that a little bit at the finance committee. It doesn't specifically talk about payback in the legislation, as Julie pointed out, but most seems like it does specifically say what the money is supposed to be used for. So if it's not used for, though, it kind of implies that it would have to go back. And so maybe it won't, as more of the part, the lobbying efforts and how it all shakes out. But I think to be safe, it's make sure you've captured all your expenses and calculated all the lost revenue to make sure you keep the CARES Act. And I think the legislation, a lot of these programs are kind of loosely written, is that some hospitals, and you guys would be a good, you go into it strong, is that don't think it was intended to end up with a giant windfall of financially, but at the same token, there has to be those protections that maybe a few are going to get some windfalls, just to make sure the ones that everybody at least survives. And then even figuring out how that affects Medicare reimbursement this year with volume decreases and which expenses get carved out and aren't now going to be Medicare reimbursed is an evolving discussion with all of management and hospitals and all the consultants and auditors and cost report preparers out there trying to work our way through this evolving scenario. And, lots of little sub details into it, like even rural health clinic productivity. Is that going to be harder to meet those standards? Are there going to be blanket waivers for that? And endless other things to think about. It will make your financial statements you're getting on a monthly basis probably be more of a challenge to be useful than normal because there's so much uncertainty. Any other questions on that?
No, thank you.
Yeah. On pages 32 and 33 is the second of the two auditors' reports. Because you're a public hospital district, we also issue an opinion or report in accordance with government auditing standards, where we report on internal controls over financial reporting and compliance. The main takeaways of this is there's no material weaknesses reported, no significant deficiencies reported, which is a good thing. And that's not a given. We do issue material weaknesses and significant deficiencies in audits we do. So it is an accomplishment not to have this. Maybe half have it and half don't, roughly speaking. I don't keep a great running total of that, but I do know that I mentioned material weaknesses often in these types of reports. So an accomplishment for your Scott and Jason and Kelly and the rest of the team of giving us the information we need and having accurate financial records. That's the audited financial statements. Any questions on that before I go into the financial indicators? The financial indicators we provide as really a byproduct to the audit. It's not required by the audit, but we have all this information and just kind of gives it a good visual picture of the districts, the hospitals, healthcare systems, financial health and trends. And so you'll see 3 or 5 years trends on most of these, and some of them will have comparative information with medians of all the hospitals in Washington, and then like-sized and like-type hospital medians to compare to. And the first one is total margin. And generally, we like to point out that you want to be in the 3 to 6% range, and you have been. And what's interesting is you'll see in that it went up 1.2% from the previous year, but that's also taking into account $1.4 million less tax revenue that was included in the 3.1. So that increase, your operating increase, made up for the tax decrease plus some. So a good solid place, but puts it in perspective. It's like that's a really good number. It's kind of right in this, not real high and definitely not low. Operating margin. This is a little more, shows a little more of the dramatic increase of your operating results from around in the 1.5% operating margin level to up to 4.1%, which without tax revenue is where you really need to be. If your operating margin does need to be in that 3 to 4% range if you want to have a total margin of 3 to 4% or 3 to 6%. And so kind of right in there where you want to be. So good. Days cash on hand, very steady between the last 2 years. And actually, what's probably doesn't show real well is that 138 days is made up of 30 of those days are your bond funds that are set aside, or 26 of those days are set aside for your capital projects from the bond proceeds, and another four days are your debt service fund. And the bond funds are less this year, so that little bit of increase, it means your operating cash and your kind of more unrestricted reserves increased. And you have 40 days in your operating cash and 68 days set aside for capital acquisitions in the future to get to that 138. I always think it's interesting is that you have $29 million, a little over $29 million of cash and cash equivalents and investments. And I always think this is kind of, put things in relation. It's $212,000 a day for your cash expenses to run your operation. I think that helps to see the perspective of what all the numbers mean. So also, I don't know if I mentioned this earlier, but generally you should have at least 90 days operating reserves, and you do. Current ratio, current assets compared to current liabilities, a measure of liquidity, anything above 2 is fine and good solid number there, no issues. This one, capital equipment expenditures percentage of annual depreciation, is not a perfect measure, but an attempt to show, are you replacing equipment at the same rate that you're using it up? The equipment you purchased that year compared to the depreciation expense on equipment. The years will bounce all over the place, but over time you want it to be over 100%, which it is, meaning you're replacing your equipment as fast as you're theoretically using it up. It doesn't take into account leases, and it doesn't also account very well for the fact that a lot of equipment and assets are used longer than their estimated useful life when they're acquired. Long-term debt to net position, just your debt to equity ratio, going down a little bit as debt's paid off and you're having a positive net income. Nothing too noteworthy there. Days in net patient accounts receivable, the average days to collect, and you can see that before the Cerner implementation, you were down at 46, which, under 50 is considered pretty good. You can see that with the medians, that would be significantly better than half the hospitals. Then it jumped up to 83, and you really kind of held steady with it through the year. So your cash flows are now even, with the goal to bring that down over time back closer to the 50 range. And gross days in accounts receivable just shows that as well. So pretty consistent between the years of how long it's taking to collect an account. Contractual adjustments. This one it tells you how much of your standard charge is not paid by Medicare, Medicaid, or commercial insurance payers. So of every dollar you charge, you're only collecting 55 cents from all the different payers. So very steady through the years. With this one, you're just looking to see if it's going up or down significantly, which would tell you that your payer mix is getting better or worse, or if your price structure is getting significantly, maybe what the right term is, I want to say, out of kilter a little bit. Bad debt percentage. How much bad debt expense do you have compared to net patient service revenue? Very consistent through the years of just a little under 4%. And you can see compared to the other hospital groups, it's about right on track with what's in Washington, and less than the other medians in the other groups. Again, a little bit, a mixture of, in the state of Washington with Medicaid expansion, we're better than we have less bad debt than a lot of other states that didn't expand Medicaid, and also the demographics of your community and having more payers and commercial payers lowers that a bit too. This one also shows bad debt and charity care as a percent of gross patient revenue. So 2.5% about each year, remarkably consistent through the years actually. And the charity care are patients that don't have the ability to pay and have applied to the hospital to say they don't have the ability to pay. By bad debt is patients that theoretically have the ability to pay, and then billing errors and correction, things like that fall in that category as well. There's always bad debts that would be charity care if everybody submitted their financial assistance application and through the process. So charity care is almost always a little understated, and bad debt's almost always a little overstated. But low numbers compared to most, towards the low end. Full-time equivalents, the number of people it takes to operate and provide the healthcare to your community, just a little bit growth there. This is not a perfect measure because it doesn't include contracted labor and contracted positions, which can fluctuate a little bit from year to year as well. But it does represent your largest cost, and so just knowing how that plays out from year to year is important. And the growth is there because your system is growing. You do more than you used to do. How much does each person cost on average, including benefits? $107,000 includes every employee, nurses, physicians, mid-levels, housekeepers, dietary, all the tech positions, support departments, and the like.
Tom,
And then the net patient.
Tom,
Yeah.
sorry to interrupt. And again, I don't know if this is a question for you or if it's for Amanda or what, but is that trend consistent with sort of workforces generally? That I know it has to go up because of inflation and all that, but I'm wondering if that's, if that's consistent with what's typical.
The number is, this is one number that is really hard to compare to any other hospital because
Right.
everybody's mix of services is different.
Oh yeah, I'm not so much talking about the raw number, but the rate of increase is what I was thinking about.
Oh yeah, that's not very much of an increase. And actually, the next slide I think actually helps answer your question a little bit more too.
Okay.
Because it compares the FTEs to the actual growth in your net patient service revenue.
Yeah.
So you had more revenue and you had more FTEs, and so the revenue per FTE went up, which is a broad measure of productivity. If this was going down significantly, that would be where we added people, but we didn't really generate any more revenue.
Yeah, it was kind of, I guess, maybe it was a question about whether our salaries are keeping up with the rate of inflation or something like that.
Yeah.
You can answer that.
Like you said, you would expect it to go up. It does include like health insurance benefits and things, which can kind of jump all over. Some years you have big increases and some years you don't have big increases with the way health insurance goes. And so it does include health insurance and all the other types of benefits as well, which can affect.
Yeah. And this is Amanda. So I don't know if this is relates to your question, Matt, but separate from this financial data and this great overview from a financial audit perspective, we also partner with Milliman, and they have a range of many other hospitals in the state. So we actually have a separate process for compensation market data, and I'm happy to talk to the board about that at any time and answer any questions. So. Okay,
great. Yeah, I'd like to. That's an interesting topic. It's not really pressing or anything, but it made me sort of wonder whether we're keeping up, keeping up with the market. But
and this is.
This is Julie, and one of the things that will be interesting to see between 2019 and 2020, if you'll recall, the Washington state minimum wage took about $1.50 jump on January 1. And so large components of our labor force here, we had to make adjustments to the wage schedules that we have for them in order to keep up with minimum wage, and then to be if you'll recall, a few years ago, the board made a commitment to be better than a minimum wage employer. So we had a whole group of employees who took a double-digit increase at the beginning of this year. So as I was looking at this the other day, I thought it'll be interesting to see what happens, because Tom also has a graph here that shows physicians and other employees. So it'll be interesting to see if that other employee piece between 19 and 20 takes a jump. So.
Okay, thank you.
Yeah, and that's the slide I just turned it to that Julie was mentioning.
Oh, great.
The red, the red one is and this is just salaries, doesn't include benefits, and it's just the no, but the red one includes everybody, including physicians, just salaries, and the blue one is all salaries without the physician salaries and the physician FTE. So you can just see how much the physicians impact that ratio. But you're right. What Julie's saying is the blue one might go up a little more than you normally expect, because that's the employee group that's going to get the bigger raise. And then the last two slides, they're on here, but we talked about those at the finance committee, and there's nothing of significance that needed to be necessarily talked about here. You really wanted to talk about it. John and Bob can fill you in.
John and Bob, was he right? Nothing of significance there?
Yeah. I think John and Bob didn't want to hear the whole entire presentation twice in 3 days.
No,
it's a reasonable request. Yeah.
It actually makes you feel better considering all the chaos that's happening and how the numbers are going to shake out, and how the hospital with Julie's leadership tried to maintain everybody's jobs and keep them going. And we knew that revenues coming in was going to go down. So yeah, it makes me feel a lot better.
So I don't mean to bore people, but I just have to spend some time talking about the results of this audit are in such large part due to the work that Jason and Scott and Becky have done on revenue cycle and their real focus there. And then Kelly's ability, I mean, there are no surprises. There were no audit adjustments, and which was not the case a few years ago. Kelly has really taken the reins on that, and we go into the end of the year pretty much knowing what to expect. And Kelly's done a fabulous job with that. And then the way Scott and Jason and Becky Litke have manhandled the revenue cycle and really squeeze every single dollar out of the services that we provide really is reflected in this financial report. So a lot of good work. This was not an accident. So
great, thank you. Any other questions for Tom? Great, thanks, Tom.
All right, thanks. Good night, everyone.
Good night.
Thank you.
So next we have COVID response.
Bob, could I just say one thing?
Go ahead, Scott.
We do need to have a motion to accept the audit results.
Yes, thank you.
I would move to accept the audit results.
Second.
So we have a move and second, moved by John and second by Erica to approve the audit results by Dingus Zarkor and Associates. All in favor say aye.
Aye.
Aye. Aye.
Aye.
Any opposed? Aye. Great, thank you. Thanks, Scott. Yeah, thanks for that reminder.
Thank you.
Okay, COVID response.
yeah, I had hoped that I think Carrie Barr and Vicki are both on, and I'd like to have them talk about what we're doing to open our ambulatory services, our clinics up again in a safe and reassuring way, and what we're doing in surgery, and again with the focus that we are doing everything we can to reinvigorate the revenue cycle, at the same time retaining our ability to really pivot should we need it to that surge position. So Carrie and Vicki volunteered to talk a little bit about the efforts in their area. So take it away.
We did. So this is Carrie, and I only know as the clinic part, and I will bounce this over to Vicki when we get over to the surgery part. But we really had a great partnership through this surgery relaunch. Like most of our businesses in the community, we had to do this a couple weeks ago of figuring out how to reopen in a different way. And So Vicki and I met with Mandy Olson with Infection Control, with Amy Krogstad, the Director of Surgery. We involved our surgical leads, our surgeons, anesthesiology, and our nurses in surgery, just to make sure that the plan that we had felt safe and concise to everybody involved. And once we got to that point, we have decided that really, in order to be able to maintain and keep a really good gauge on our PPE and other resources, we are only scheduling out for about 2 weeks in advance. And this is just so that we don't end up where we were before, that we have people booked out for months, and then we have to cancel that. So we are testing these folks. So we're doing our
Meaning you're testing for COVID?
COVID, yes, COVID, yes. It's not an SAT. Luckily, or else I'd never end up with surgery, right? So we're doing COVID testing. We're doing that 5 days in advance. We are finding that we're just getting to the edge of that window now, because many other organizations are testing as well, COVID testing as well, for their pre-ops. So it is starting to clog the system a little bit, the lab system, just a bit. So we're keeping an eye on that, and just every day, just kind of adjusting, like we have with every line of service that we offer here at KVH, just adjusting daily as needed. Vicki, I'll turn it over to you and take any questions.
Hi, this is Terry. Can I ask a question about the testing?
Yes.
Can you hear me okay?
I can.
Yeah, okay. So I was curious about, it's the 5 days. Are we doing that because that's a turnaround time?
Correct. Yes,
Okay.
we're doing, and we know that, so pre-op tells them we're doing this 5 days prior to your surgery. And then after you have that surgery, please reduce any potential exposures that you get, try to really isolate yourself. And it is really around that turnaround time. We were having about a 40-hour turnaround time. And like I said, sometimes we're cutting it pretty close. No pun intended with the cutting.
Okay, all right. I was just curious because I know some hospitals are doing it a lot closer to the day of surgery, so that way if they get a negative, they don't have to worry about the patient being exposed for 3 or 4 days.
That would be ideal. And we looked at that initially, and again brought this to the team, and Rhonda Holden, Stacy Olea was all part of that team as well, and making sure to set that time frame. And until we can get a really good, reliable time frame, and I'm actually very grateful that Rhonda and Stacy had said, be conservative with this a bit, because they gazed into the crystal ball and said things are going to clog up, and sure enough, we've, like I said, ran into that.
I think we've had a couple of mornings where we had the patients show up and we didn't know if we had results from their test yet. So.
Okay. All right.
Yeah,
Well,
it's caused some high blood pressure for Vicki Maturo for sure. So Vicki, take it away.
all right. Well, maybe she needs some medication then for high blood pressure. All right.
Vicki, you want to?
There we go. Okay, perfect. Yeah, I think Carrie hit most everything. What we wanted to do on the surgical side was just to make sure we did not overextend ourselves, because quite a few of the surgeons had a backlog, of course, of patients they really wanted in there right away. And so we were able to mitigate most of that. Amy offered, the ortho group was the biggest group with a lot of patients waiting. And we did offer them some additional block time that wasn't being utilized. So I think we're catching up quite well, actually. There's been a couple of late nights, but we try to avoid those because there's other emergencies that happen. The testing is a big deal, but the patients have been very understanding when we call them and tell them that we cannot, or we don't have results. They really understand our situation and have been very gracious about that. I think we've only had to reschedule one of those patients. The nursing staff is happy to be busy, as are the surgeons. I think most of them are understanding that we need to be flexible and nimble still, just to make sure that we have inpatient beds to take care of sick patients if they should come in. So we send that message out to pretty much all the teams. We haven't started doing totals yet. I think we're going to be doing total joints probably in the month of June. I think we've got a few scheduled then, just because they take care of more resources and their extended hospital stay. And thankfully, most of our COVID patients in the community have been recovering at home, so that's been on our favor as well. But we just want to remain nimble so that we can adjust if we need to, start shutting some of these services down. Any questions?
So, Vicki, so other than the testing, are we just having patients like come in and wait for their surgery time more purposeful, or how? I'm not quite sure how.
Yeah, most of that scheduling is done at the clinic. So the clinic has been notifying those people that were put on hold. Of course, the urgent people and emergence gets done right away. And then those more elective type surgeries get scheduled pretty much as they come in, like in order.
So as they were removed, So as they were removed from the schedule, that's how they're coming back on. So it's and yes, you're absolutely right, Vicki. If there's anything that's would cause them harm by waiting or is urgent, they're getting put on or have been getting. We have not been delaying those surgeries. If there is going to be any harm to the patient whatsoever, those were never coming off of the schedule initially. So these are the ones that have truly been, hey, I'm doing fine, and there won't cause any harm. There won't be any additional harm by waiting. But yeah, as they were taken off the schedule, that's how they're coming back on.
Okay.
So I want to let the board know we have had some inquiries from providers outside of Kittitas County and from facilities outside of Kittitas County. In fact, one of the larger hospitals in King County wanted to know if they could send a block of patients over to Kittitas County to be tested preoperatively. We've had some surgeons from Yakima contacting us wanting to know if they can use OR time. And as tempting as that is from a revenue perspective, we have an obligation to this community, and we're very mindful of that as we open up and make these resources available, we really need to start with our own surgeons and our own providers and make sure that our resources are available to our own community. I think what it is, we've looked at for years at these graphs showing that we're losing market share over to Seattle and to Yakima. What it is an opportunity for us to do, I think, is capture some of that market back. We have, I don't know about you, but I wouldn't want to be going to Yakima for surgery right now. And I think their capacity to manage surgeries is going to be really, really pushed for a while. So, we're not saying KVH is for Kittitas County residents only, but we're here to serve this community, and we're not looking to have a bunch of outside providers come in and use our ORs or our resources or our testing capacity. So.
Great. Yeah, anything else, Vicki or Carrie, on COVID response?
Not from me.
Okay. Great, thank you. So let's move on to reports and dashboards. We'll start off by quality with Mandy Olson.
Let me just make sure am I unmuted?
Yep.
Okay, and everybody can see the dashboard up here?
Yep.
Okay, I'm manning the documents, by the way, so if I do anything stupid, please tell me what you want to see on the screen.
You're doing good.
Okay, so we did have data share and QI council this month, so I'll go over the dashboard briefly here. And so first thing I want to just point out with sepsis is the one failure here in the last month was about a patient with urinary tract infection and sepsis. And they did not meet the antibiotic guidelines because you are supposed to either give a broad spectrum antibiotic or 2 antibiotics, and they did not give that second antibiotic in the time frame. So patient did receive all the treatment they should and had a good outcome, just didn't quite meet the time frame. So for that second antibiotic, and that is why that looks like that. About sepsis antibiotic timing, this is a new measure this year on this dashboard, and really trying to see, this is specific to the emergency department, how we're doing in identifying and get that antibiotic given within an hour. And so that's where we're looking at that median time. One of the things Anna has discovered in the last month is that we are measuring this differently than other hospitals in the Washington Rural Health Collaborative, where we report this data to. And in the process of looking into that and talking with Dr. Lindsay about what he wants to do with that measure, they've actually discovered, oh, we can look at this a few different ways, and I think it will help with the overall time. So they're working closely on, is this the time from when the patient walks in to when we start thinking, I think sepsis is going on here, or is it the time from when we've thought, I'm concerned for sepsis, and the physician places the order? Is it the nurse approving the order, activating the order, the pharmacy getting the medication to the unit, or is it the administration? Where is it in that whole time that we're struggling? So it's really a great opportunity to drill down into the reasons for that time. Median time to CT, so we did bump up here in March, and we, most of these cases it was after hours, and ONRAD did receive a financial penalty for not meeting this quality metric. I did hear in MEC this month that there has been, this was March, remember this data, there has been a huge improvement with the service, the radiology services. So I'm hoping we'll see that here in the next few months. We did have one patient who received TPA. One thing I'll say about this measure too, this stroke measure, there are certain reasons patients are excluded from the measure that we report to get with the guidelines. But because our numbers are so small, the times that we give TPA are so few, the stroke team wants to look at every single time that it's given to evaluate if we could do better, right? If there are opportunities. This one patient in this month would have been excluded from is excluded from the national data, but they included it here. They had increased blood pressure and they needed to wait until that blood pressure came down before they could give the TPA. So that's the reason for that high score this month. Let's see. I do just want to point out restraints, a lot of improvement. Jeff Holdeman, the med surg director, wanted to give kudos to informatics for getting changes to the order and care plan in place, and that's really helped. And in these 10 cases, 10 patients where they had restraints, there was only 1 hour of documentation missing. So really great improvement in restraints documentation. We did have a couple of falls in the outpatient setting where there was injury. they were just bruises, swelling. One of them was a toddler in the pediatric setting, so we still don't want to see that, but it's kind of understandable how that may have happened. No needle sticks, which is great. We did have one surgical site infection, which was a hysterectomy, which is not common for us at all. It was a very complicated case. Okay, Days, go ahead.
This is Erica. Just, you mentioned that there was a pediatric case with the falls, and I guess I've always assumed, perhaps wrongly so, that the falls count was just for hospital campus. Is it clinics as well? Or
yeah, we report all here. What gets reported to WISHA is only inpatient data, so it doesn't even include observation. But on our dashboard, we look at all across the entire campus. What it does not include is employees or people who are visitors. It's just patients.
Okay, thank you.
Yeah, there's a lot of different ways though we can tease out that falls data that our falls team looks at quarterly. Let's see. Days to referral completion. They've been working on kind of leveling the workout and cross-training amongst different staff to make sure that we can try and bring that number back down to target again. I don't really have anything on the pain reassessment after medication. We flip to the next page. Really great work in home health and hospice, 100% at the home health referrals, so timely start for physical therapy. Great job in the improvement in management of oral medications with home health. You may notice that this, the benchmark, the target has increased slightly too. When we have a full month or a year of data, they update it. And so even with that benchmark going up, we met it in March. And in most of the cases, it's a lot of times that the patient's really not appropriate to improve. They either transition to hospice, they end up discharging, they have a caregiver, and they're unable to care for themselves. So we're not expecting to see improvement in management of oral medications, or so they're still working on that though to make sure the staff are understanding the documentation to support that. And then improvement in pain interfering with activity, some of the same reasons, but so with the benchmark went up a little bit, we're right there. And some of these patients have chronic pain issues, so it's not expected that their pain would improve. So they're working with the staff to make sure the documentation matches the measure there appropriately. And then hospice visits near end of life, just really doing great still with that. So that's good. They have a imminent board to notify the team. They've just really been using their tools well. And again, this is quarterly too, so this is a longer period of time.
I'll just jump on that and say that one of the trends that we've seen in the last few months is we're getting later referrals, which makes it harder to meet that measure. We've had a number of patients who passed essentially on the day of the start of care, which makes it hard to get nursing plus 2 additional services in.
Right.
But there was one start of care very recently where the patient was on services for 24 hours and received care from a nurse, from bath aid, and from chaplaincy.
Yeah, it's a really great work. We have a really exceptional hospice program. So then Medicare wellness visits, this really isn't surprising. A lot of our patients canceled themselves starting in March. Workplace violence events. So we're having some issues with the data. Well, COVID got in the way, to be honest. I have to work with the data, and I have not had time to scrub this the same way that I would. In addition, though, we had a lot of discussion about this at QI Council. There's a lot of different ways we can look at the data. And so the expectation in the future is that we will have a robust report and review about workplace violence measures all the different metrics, the deep dive that you can do with them, and more benchmarking discussion at a future QI Council. Did I get that right, Matt?
Well, and I think that's a report that would also be helpful for the board, kind of the objectives that we have, because there is the reporting, the OSHA definition of what workplace violence is. But there's also a move at KVH to really shift our culture around this. And, you know, we have signs up at all of our registration desks and inside our patient rooms, letting people know that we have a zero tolerance for aggressive behavior. So it's part of it is this real, you know, employee on employee or patient on employee kind of violence, but it's also this culture that says we will not tolerate that. And caregivers have a tendency, it is possible for caregivers to come to work thinking that, you know, being shouted at, having aggressive behavior on the part of family members or patients is just part of the job. And we need to give them the tools and the support as an organization for them to understand that that is not the case. So further on in the year, I think we would like to bring this to the board for a really robust conversation about all the things that workplace violence can mean.
Yeah, this is something that came up at QI Council.
Go ahead.
Thanks. This is something that came up at QI Council when we talked about workplace violence. And I know that some of us, when we were running for election, this was brought up to us. And it sounds to me like the administration at KVH is doing quite a bit to address this, not only to change the culture, but more specific measures like having the security officer, I don't know if that's what they call them, but that's something that a lot of KVH employees had wanted for a while. And so they're going to talk about it briefly. I mean, Julie just talked about it briefly now, but later in the year, there will be a fuller report on that. So I think it'll be really interesting for us to all hear about that later. Terry, sorry, go ahead.
Oh, I was just going to say that one of the things that we discussed is the actual labeling on that graph, workplace violence events, is a reporting thing. It's not a name that we came up with. And when you see that, you wonder whether is this people running up and down the hallway with knives and guns and things like that. And it's not. And that's one of the things that, you know, like Julie and Matt were talking about, we're going to look at it better. You know, this is when somebody's standing in front of you and screaming at the top of their lungs or doing other things like that. So I think it's important for us to kind of look at that. But if somebody sees this, since this is a public meeting and they have a question, you know, these are not places where people are running around and, you know, with dangerous weapons and things like that. This is a lot of other type of violent things, because having somebody stand in front of you and screaming at you is enough to cause a lot of other issues.
Well, yeah, I mean, we want to be careful not to exaggerate the risk. I mean, it's true, no one's running around with guns, but there are, I mean, these are obviously serious things, not only being yelled at, but I know that there's, I mean, especially with people who come in with mental health issues, there's some problems with that, or people who the cops bring in. I know Mandy is much more familiar with sort of examples of things like this, but it's good that the administration is addressing this aggressively. We just had a case announced recently, you know, a threat. So it's good to address this aggressively, even if it's not what we might normally think of as violence, sort of people running around with guns and knives. So you're right, Terry. But yeah, it's good to be vigilant.
So just to be clear, this particular measure that does show up on the QI dashboard is a OSHA measure that's standard in the United States. It's looking at the number of harm events associated with workplace violence. And they say that the definition of workplace violence is any act or threat of violence, physical violence, harassment, intimidation, or other threatening, disruptive behavior that occurs on the work site. So threats, so verbal intimidation, it's really anything that our employee says, I felt threatened, this was workplace violence to me, then it meets that definition. So, and it's over the number of full-time equivalents times 10. So it's a rate. There is a challenge with rates in that, and this measure period is that it is dependent on reporting. It's not just hard data. And there is a feeling that, like Julie said, some clinicians feel it's part of the job, or they feel bad for the patient and they don't want to report it because they don't want to stigmatize the patient, whether it's because of mental health or drug abuse or whatever. But there's a lot of reasons why staff may fail to report it. So there is a feeling that there's a lot of underreporting out there. I don't think that's necessarily true at KVH. You can see that in our other measures, like the one right next to it, employee reports. We have a reporting culture here that's really important to have a safety culture, but we do have a reporting culture here. I think our reporting is fairly accurate. I know of a few cases where it's like, we heard this happen and no one's reported it. So, but that's really rare that I hear of an instance and someone hasn't entered it into Verge. So it is an interesting name, but that is the OSHA name. It can be actual violence or threats of violence. It can be patient on employee, visitor on employee, or employee on employee. There's a lot of different ways that you can slice and dice this, and that's why I think it will be a really great discussion when we have some more aggregate data and can drill into it a little bit more at QI Council.
Yeah, I'm personally glad that the hospital's really starting to, or has been looking at this for some time and is continuing to look at it, because it just seems like things have changed and there is a little bit, more anxiety out there in healthcare as a whole. That's been going on for several years, and they've been even at the national meetings in Arizona, they were talking about this. So I'm glad that we're really doing work on this. Thank you.
Yeah, and I think part of it is bringing to you also our leadership what we've been doing. So there has been a lot of ongoing work, but there's no reason not to bring you into it and let you understand better what's happening. Mm-hmm. Any other questions about workplace violence? Okay, and then adverse medication events, we had 0, which is fabulous. I'm going to jump over to the right here with the reports of occurrences. 2 of these are related to those falls, and then another one was actually a staff fall, unfortunately. And I don't have the details on the other 2, which is okay. But good thing is you see the employee reports were really up, and yet our rate didn't bounce up significantly. So we saw some great employee reporting of issues and concerns they had, and especially with their safe board, which to me means teams are really working together and talking about problems and concerns they have. I know a lot of this increase, but not all of it, is in particular with imaging, where they want to, they're working on those turnaround times and the with ONRAD and trying to improve that, or not the turnaround times, the time to the report. So really good work here. I'm excited to see. A real bummer that we didn't have any positive feedback in the month of March, but I mean, there's other positive feedback. We didn't get any formal letters of positive feedback. We got some great feedback on Facebook and in other venues. We also did see decreased complaints though in March, so that's good.
Real quickly, after QI, Michelle Whirl sent out social media. What was that called? Not a temperature report, but Michelle, are you there?
Yeah, it's a sentiment report.
That might be something we want to bring in the future, because it shows who's liking us, who's following us. It really was very interesting, because just like with so many other things, I think that's where we're getting general feedback. We get the thank you cards and nice little notes and things like that, but an awful lot of that is coming through social media now, and it looks like Facebook at least has some really good tools. So,
okay,
I'll be sure to include those.
So then, these are the glossaries. They should be in your packet if you need them. Then we also did go over the patient satisfaction dashboard for just the second time this month. And I'll just quickly reorient you to the fact that we did change with the board QI Council's approval to a percent top box instead of a percentile rank now. So all of these are based on percent top box on a scale of 0 to 10. That's a score of a 9 or a 10, like you'd see with the overall quality of care they received. In the willingness to recommend, I believe that's a 4-point scale, so it's highly likely to recommend would give you that top box score. We set an overall target of 75%, so you know we want to see at least that gives us that those very highest scores. You know, but that was just kind of a let's just put that up there and see how we do. These dotted lines on here represent when we transitioned to this new platform to Press Ganey last year. Previously, we were in HealthStream. So you can see where we've transitioned in surveys or services. In outpatient surgery, they were doing kind of a general outpatient survey, and they switched to a survey called OAS CAPS. It's specific to outpatient surgeries. This outpatient surgery is a really good example of why I think moving to percent top box is really meaningful. When you look at the percentile rank, well, one, it's dependent on how other people are doing that month, so it may not really reflect any change we've made to things. But also, they would be like down in the 9th percentile when they're, you know, at 90% top box of different individual metrics. So it really felt like that's not helpful in helping us understand where we need to improve. One of the things Julie had talked about working on last year too is kind of narrowing this gap between ranking and willingness to recommend, making sure those were closer together. So there's been times, like MedSurg is a good example here, where they said, yeah, you guys are awesome, but I'm not sure I'd recommend you. So how can we bring that sentiment closer together for folks so they do trust us? And that was part of, you know, our mission and vision statement in the future too, is being someone our patients would trust. So overall, looking really great. There's obviously some opportunities. Press Ganey, I'll just remind you, and I'm sorry if I've said this a million times, but they did transition to we switched to Press Ganey last year, got everyone oriented, all our leaders, and then Press Ganey decided to change their platform. And so right as COVID was hitting, Amy was orienting our leaders to this new platform and how to access their information. So I do think there's a lot of opportunity here that's been kind of waiting. And I think Amanda has gotten started working on service, and I don't want to steal any of Amanda's thunder, but she's been using one of my new staff and they've been digging into this patient satisfaction data just recently, looking at our survey of patient safety culture, looking at care and service reports, and seeing where we have opportunities. So I don't want to say a ton more about that, but it is, we've got this great new platform, we've got these initiatives, and it's starting to be used, I think, in a really meaningful way. As well as the providers are starting to look at this data. So clinics overall looking really great. Home health and hospice. This is a different product than Press Ganey, though. This is SHIP. And then if you recall, we transitioned to a paper survey for our lab and imaging services, and Rhonda's been collecting that. And I think she put it in the board report last month, but we're going to work to get this all in one place so you can see it all in one place. They've got some really great data they've gotten from there too. So I'm trying to think, was there anything else anyone else wanted to mention about patient satisfaction before I move on? It was rehab. Oh, I do want to mention rehab. They had, you'll see their response numbers. They were part of the outpatient group and did not have a rehab-specific survey, and we transitioned them to a patient-specific survey, or a rehab-specific survey with, and did paper surveys as well, and we've really seen a much better response, and the feedback they're getting is helpful. So Other than that, I have my report that's in the packet. Let's see, did I skip it already? You have it also, but I didn't know who could see their screen. So just
And you're still looking for folks to
yes,
for PFAC.
yes, we are. I haven't gotten any additional nominations. We did have that PFAC, and we've had 2 already this year, right? Yeah, so well on our way to having 4 a year. It would be great to add some new members this year. So, you know, there are just 4 meetings a year. We've already had 2, so it'd be 2 more meetings, and really helping us understand what our patients expect, so that our teams doing improvement work have that point of view and can keep that at the forefront when they're making changes. I think that's all I had.
Great. Any questions for Mandy? Thank you, Mandy.
Yep.
Good report. Julie.
Okay, so again.
Sorry, Julie, sorry to interrupt. I just wanted to mention that on Tuesday, there's going to be a forum, an employee forum, and we're going to be presenting the Safe Catch Award. I'm going to the hospital to help do this somehow. So welcome phase 2. I don't know if someone's going to be join me anyway. So
I'll be there at the very least with you, Matt, and we'll make sure that you're safe. We'll
yeah, all right, that's good. I'll bring I'll bring a snow shovel or something to hand it to him. So that'll be good. Anyway, so keep your eye out for that. It'll be good. Sorry.
The employee forum is on Tuesday at noon, and I think the intent was to ask Terry and Matt to be there to do the Safe Catch Awards, and I know Mandy Olson and Mandy Weed and others are working on how we can do that and not violate any of the rules. But we talked about doing it in this meeting, and it is just really important, I think, both to the board to be able to be part of the celebration, but the employees and the folks who nominate and who receive the Safe Catch consider it just a really special honor to get that award publicly. And whereas the public meeting, we usually have 4 or 5 people in attendance, the electronic employee forums, we've actually seen over 100 at every one of the events. So it's exciting to be able to do this because it is a great celebration for
I'm really looking forward to it. It'll be good.
Yeah. So hopefully, Terry, you'll be able to be available as well for that. So
yes, I'll be able to be there. I'll be 6 feet away from Matt, I'm sure.
Okay, we'll figure this out. We can do this.
Or farther.
All right, I actually have a 6.5 pole at home. I can always bring that along with me.
All right.
Anything beyond 6 feet is entirely your personal decision. So.
Okay. I've been practicing social distancing my whole life. This is like my major league. Anyway.
You're in your zone, Matt. You're in your zone. Right.
Introverts have been waiting for this their entire life.
It's paying off.
Okay.
Sorry to interrupt, Julie. Go ahead.
No, that's okay. So you can see in my report, I talk a little bit about what's going on with COVID. I do want to make myself available to answer any questions about our relationship with Prestige. That letter has gone out canceling that contract effective for medical director services. That cancellation will be effective towards the end of August. And so now that we're in phase 2, if everything goes according to plan, it's my understanding that we would anticipate going to phase 3 in about mid-June, which means phase 3 would allow us to hold this meeting again in person. So again, we'd probably have to have more than one location. So we'll be working on what that format will look like. The governor's waivers that allow us to do it this way actually expire at the end of this month, but we'll be working with all of you to see, I'm sort of envisioning making a public space available in one area of the hospital. We still have to maintain social distancing, but we can gather in larger groups. So it may be that we'll be using the admin conference room for some folks, the ABC conference room for the board and others, and a location out at the mezzanine or something for public who wants to attend. So we're thinking about how we might do that. And if you have any ideas, please let us know. Any questions about that? You should have received, at the end of this public meeting, we have an executive session plan. You should have received a meeting just a few minutes ago from Mandy Weed inviting you to that. We wanted to do it that way so that the meetings wouldn't be confused. Let me see. I had asked Manda Scott to give us some updates on what she's doing with staff development and then how we're doing with the employee attendance.
Yeah. So from a workforce perspective, I'll kind of go through some operational items first, and then would love to give everyone an update on staff development initiatives as well. So we have maintained pretty steady in terms of leaves. So people asking for leaves related to COVID, for childcare, other things, that's been pretty steady since the last time we talked. So nothing new really to report there. HR, workplace health, and infection control have still had daily huddles to make sure that we're coordinating guidance to staff if they are exposed or concerned about being exposed or out of work with any reason related to COVID-19. We're coordinating that pretty closely and sharing ideas with each other, keeping in touch with the guidance. So that's also been going very well, and I'm very thankful for Mandy and Anna and Ryan with that work as well. The other thing I really wanted to point out, and especially in terms with the financial discussions that Scott has been having, is that I'm so impressed with our workforce and our voluntary reduction program. So I wanted to update the board on how that went from kind of the employee and organizational experience. And as you know, we took a partnership approach, and so did you as the board, on how are we going to reduce labor costs being our biggest budget item, and especially through this time where things are uncertain. And so, you know, as you remember sending out the email in April where we committed to not making any drastic changes for employees, that was appreciated. We also offered the voluntary reduction options that we talked about, where people had the option to take low census, take PTO time, or if they were physicians or providers, the referred option would be to reduce their pension on a voluntary basis. And we had an outstanding response to that. So we had about 40 to 50% of our staff on a voluntary basis submit actual forms to contribute to that. And people were very thankful for KVH's approach and having options and being able to do this on a voluntary basis. And some people were actually relieved because they weren't sure how they were going to manage their own health or childcare or things like that. So again, I'm just very impressed with our KVH staff, and I want to really commend that you know, we would be in worse position if it wasn't for people contributing and just doing that in a positive way. So we've also maintained relations with our union, and we did have an MOU. We had some negotiating on a very simple MOU. We were aligned for the most part on what we were asking. It was just more clarification of procedures and policy for the voluntary reductions, but we were able to do that. And Julie and I had a really great meeting with our Teamsters for our service union as well. And they were very supportive of our approach also, as well as our labor attorney that we've, of course, continued to work with. So we've been getting a lot of compliments on that. It has been a little, of course, challenging for the managers to maintain those schedules, especially as things pick up. And I do think managers are trying to maintain, you know, helping the staff contribute in a way that works best for them, but also preparing for the future of increased cases and visits. So I do know that the managers have been managing that very well. We did kind of a very informal pulse check by email with the managers on was this effective for you to reduce labor costs, and how's your staff feeling overall, kind of just mental health check-in. And we got good response on that too. Nobody said that their teams were in crisis, which was a good thing. Challenging times, but they're managing. And everyone said that it was effective at some level. So very good response there. Any other questions on that? That was kind of a big part of our conversations last time. So I wanted to just see if there's any questions on the response to the voluntary reductions before I talk about some other items.
So do you think we've reached the goal with like 20% overall reduction?
Yeah, I'm feeling very positive about it. I'll leave that more to Scott, and Jason Adler and I have been having some check-ins on that. The response that we've gotten so far, we've seen great results, and that was actually the pay period before the effective window that we're tracking. And we already saw a huge increase in low census, that people were volunteering early for this program. So we won't know more until this last pay period, the first one under this review period, closed. And Jason and I are looking at that data. We plan to have something more concrete from a goal perspective, and Scott can certainly talk about that in terms of financial goals. But from an initial review and staff contribution, we're definitely on track for those goals from our perspective. One number that we pulled was that our overall number of low census hours, I think under one of those pay codes for low census was 1,800 year to date, and we had like 800 just in one pay period. So when we're looking at all those numbers, we had about 50% of the year to date for contributions for low census hours from staff just for one pay period. So huge increase that you can already see in numbers, and we'll know more of that as we go through this process for the other payrolls. But great question. We are trying to keep a pulse on that.
I think I can put a number on that if you'd like.
Yeah, that'd be great.
The payroll that we looked at, it looked like about $120,000 to $125,000 expense reduction for that voluntary use of PTO. And so if we extrapolate that over the 2 months, we're looking at labor savings of almost $500,000. And then in addition to that, we have we had requested that our vendors voluntarily reduce some of the fees that we charge over a 2 or 3 month period also. And the total, we've had a variety of responses. The more local businesses and Washington State based businesses have tended to step up and help, and the bigger businesses that not local, I would say, have kind of declined. But the total on that so far, and it's still a work in progress, is going to be about $203,000 so far. So between the two, we're looking at nearly $700,000 of savings that essentially voluntary by either the employees of Kittitas Valley or of the vendors that we work with.
Did you include low census in that too, Scott, or just the PTO? And then there's also the pension rates as well. So there's some other metrics that I think will really help those numbers.
I was looking at an aggregate. So I was seeing about $120,000 between the pension and the low census and the use of PTO. A combination of all of that, and it may end up being a little bit higher than that.
Great.
And I would just say what we're hearing from some of our vendors is they're really we're the only hospital that's making this ask in a lot of cases, and we felt it was really important to go to the vendors at the same time we were asking our employees to help us out with this. So. And we're keeping a list of the vendors that have been real helpful and understanding as we've gone through this. So yeah, I'm really, really pleased, and I haven't heard anyone sound like they were disgruntled about this or, felt like we were arm twisting at all. So
Julie, you should also keep a list of the vendors who are not being helpful.
Well, that was implied, and believe me, we are.
I expect an enemies list on your desk or something.
I will say the Rural Health Collaborative has gotten wind of this request that we've had made to our vendors, and we've sent draft letters over to some of the participants with the Rural Health Collaborative, and they've been appreciative also. So it was kind of a unique idea that Julie or the team came up with, and it's been amazingly well received.
Great.
Yeah, excellent. And just one other kind of operational thing, and I'll talk a little bit about staff development, is I just wanted to update the board. Of course, as you've seen, it's been in county communication, it's been in our communication. about the fraudulent unemployment claims. And that has been a huge problem, specifically in Washington, but of course, across the nation. Washington was hit very, very hard on that. And although it's not a KVH net process concern, we are trying to support people as much as possible. We believe that our physicians and senior leaders and anybody who is more visible, maybe on our website, that they were targeted more than some of our staff members. But we have been helping those individuals get connected to the proper resources to handle that through the state. We've been getting guidance through employment security. We've been communicating through our cross-functional leadership huddles to directors and in the announcements to staff on what those resources are. So just a very unfortunate thing that's happening within our state, but we are trying to help people navigate that as much as possible.
So, Amanda, people are taking some of our employees' information that are taken to apply for unemployment?
That's correct. That's correct. And the information doesn't come from us, so it's not a breach in our systems. And luckily, we have good checks and balances for that. We actually partner with Washington Hospital Services to process our unemployment claims as a third party. And in this case, I really think it's helped us because it has also been just a third party, an additional review step with us and the state information as well. And we've seen things all over the board. Sometimes the employee gets a letter first that looks a little odd and they inform HR. Sometimes we get a letter first. Sometimes people they log into their Secure Access Washington website and they see that a claim has been processed under their name. It's not always that there has been identity fraud because they're just hacking the state system, but sometimes they can connect the profiles. And so they haven't actually gotten the employee's information. It's just by the time it comes back to us, we have the employee's information. So it's coming from all different angles. There's definitely no rhyme or reason with it, but we've seen it all over the board. It's unfortunate.
Wow.
Yeah.
Last I heard, Dr. Martin, Michelle Whirl, and I were all unemployed. So
yeah, and Carrie Barr too. Carrie Barr.
Oh, Carrie Barr's unemployed too. So
wow.
It's getting a little thin up here in
senior leadership.
Yes. Luckily, it's been easy to catch because people we're sitting in meetings with, we get unemployment claims for and that don't sound right. But it is very unfortunate. It's very inconvenient for those that have been had to deal with that. But the state is definitely working with people, being responsive once they do get that information that we found as well. So that's another thing. And as Julie mentioned and Mandy mentioned earlier with customer service training, staff development plan is still going well. We under coronavirus and everything going on, a big part of staff development team, our work has been trying to keep our programs that we have at KVH going virtually. So we did have a pause for things like our new employee orientation where we talk about our culture and our values and very important things. We did pause on that for a couple months, but we're getting those things back going. Team steps, new employee orientation. We have our EVADE, speaking of workplace violence, and I can talk more when we have that meeting, but we do have our EVADE training coming up next week, and that is specifically for de-escalation techniques around workplace violence. And that's a partner that we bring into the organization. We got great feedback on that. So we are keeping things going. It just looks very different. We're trying to keep things virtually, trying to keep things lower number and more class options. And it has taken some work to manage that and be creative, but we're happy to do that because we believe in those programs and keeping in contact with our staff development plan.
And are you getting a good turnout for EVADE next week?
Not as much as I anticipated. I do think, schedules are odd right now. I think some people still on low census and trying to, but so we're not full. We still have room. We'd love people to refer anybody. So we definitely have room for next week, but we still have enough that it'll be a worthwhile experience for our facilitators who are investing our time. So we're hoping to see more, and we'd love to branch out, to other groups, PSRs, other offsite facilities. So we've communicated to all of those groups and really trying to open it up to some people that didn't get a chance to go through that the last time around. So, and we also are bringing them back later in the year for a level 2. So kind of an advanced level for those people who have gotten some of the basic skills, but want to learn additional skills. So people like our emergency folks and our social workers and people who might be more exposed than others in those situations. So great question. Yeah. We also did staff focus groups, which was exciting. That's something Julie and I have been wanting to do. And with coronavirus, there was a little delay on that, but they were really successful. We didn't get a huge response on those either, but for the people that did participate, it was really great conversation, and it was all in line with the staff development plan that I introduced to all of you earlier in January. The staff were following that. They got it. They understood that they need job skills. They need to be able to have customer service and teamwork, and they need to be able to have a long-term career with KVH. So we talked about those things, and I have some notes that I'd love to share with you later on when we do a more in-depth. But really, we heard great things that were not surprising, but very affirmative of where we're headed. So that was very exciting. And then we started to introduce the customer service training. So we're starting initial planning on that. And that's something that I will definitely be wanting to spend some more time as that evolves on talking about. And as Mandy mentioned, we are taking a data-driven approach to that. So we've been talking to our staff about, we have all this data, we have the voice of our patients, you know, and how are we sharing that? How do we know where KVH stands right now with customer service? And so I'm working with a little mini work group, so a couple of Mandy's team members, and we plan to get in maybe even some of the focus group members as well for feedback. But we're going to be really talking about, what does this mean for KVH? How does it relate to our values? How do we track it? What comments and feedback have we had from our team members through engagement surveys? What does our Patient Family Advisory Council feel about service at KVH? And so we plan to have a comprehensive training that pulls some of that data together just to give us a foundation and start the conversation, so that if we do want to bring in other training in the future, we kind of know where we're starting with. And we're excited about that. We had, as you know, we were looking at Disney and partnering with a large company to facilitate some of that training. And we might still explore that and explore that with you in the future. But for now, this is a whole different strategy that I'm excited about. And it's really cool to see, to dive into some of that data and look at things in a different way. So more to come on those initiatives. They're still moving forward. Definitely the training and development world being a very different world right now with coronavirus, but we still feel really good about where we're headed.
Thank you.
Thanks, Amanda. Like a couple more things I wanted, I don't want to interrupt the conversation with Amanda. Are there any? Okay. Next Tuesday at the employee forum, the other two topics we're going to be touching on will be what phase 2 looks like for us, and there will be things that are changing and things that are not changing. We are anticipating rethinking. Again, we're going to stay flexible, but the COVID clinic, we have staff through mid-June. After that, we're prepared to shut that down. I have a commitment from Carrie Barr and the lab that they'll be able to pop that back up in 24 hours if we need to. So we anticipated that the use of that clinic or that service would change, and I think that's we're using phase 2 as the reason to change that. Also, Ron Ehrlich has agreed to take the tent down in front of the hospital. Again, they'll store it on site, so if we need to pop it up in 24 hours, we'll be able to do that. Ryan R. and Mandy Mandy Olson will be addressing our employees about, Ryan at Workplace Health has been managing exposures here, and there's just a lot of questions since essential workers in healthcare are treated differently than the general public is when there's an exposure. So Ryan and Mandy will be talking to the employees about that. So I think it's going to be a really engaged group for Tuesday. I did want to talk about some things that there's a lot of backed up material, as you can imagine, for future board meetings. I would like to use the June meeting to work with Greg and Nancy and start the discussion about strategic planning again. And Greg has compiled some articles about strategic planning in the age of COVID. We've talked about truncating that strategic plan from a 3-year plan to essentially a 2021 recovery plan, but really starting that conversation again in June with the board. I've asked Mandy and Carrie Barr to be doing some thinking about where they think the ACO work that we're doing in patient-centered medical home, there are reimbursement mechanisms attached to that, and there's also a lot of work attached to that, and just sort of their assessment for the board of what blowing up primary care in 2020 is going to mean to those programs. We've talked about workplace violence and having an opportunity to talk about that at a future board meeting. And then I really do think it's worthwhile. I'm really intrigued by Michelle Worrell's ability to look at our Facebook presence, our social media presence, and the kind of feedback that we're getting there and how we can use that and how we're using social media, particularly right now. So those are things that, as I look at June, July, and August, and we all know how great planning in 2020 is gone, but those are things that you can anticipate seeing in the next few months as we move forward.
So Julia, because typically in June we have some kind of a retreat, a planning retreat. So are you thinking later summer, having something where the board is able to?
You know, I haven't spent enough time thinking about that. I've met just over the phone with Greg and Nancy a couple times to say, you know, we have to do some strategic planning, and strategy right now is about capitalizing to the degree that we can on this situation. But what is that what is that going to look like? And a couple of organizations like the Rural Health Collaborative is talking about having an in-person meeting in June. I have this vision of this headline that 30% of the rural CEOs in the state are in quarantine following a meeting. So I don't know what I don't know what form it's going to take. I just think it's really important. This senior leadership team has not let any opportunity go as they've dealt with COVID. They've really, I don't want to sound predatory, but as this situation has presented opportunities, people like Kevin Martin and Lisa Potter and Jason have really latched on to those, and that's what I want to do with strategic planning. So
okay.
I'm not sure that was a very good answer, but that's kind of what's swirling in my plan. So, and I did, looking forward to the fall, we believe there will be a special session of the legislature. WISHA is very interested. You know, it was an absolute mess getting all the waivers, identifying the waivers that we need, getting the state aligned with the federal government in terms of waivers. So we're going to have a big ask in the legislature to make those waivers easier to turn off and on. Mandy Weed and I were talking today. We have a resolution out there about credentialing. We're looking at some language as we go into June and July that would make that resolution more automatic, so that if we are in a state of emergency or if we're not able to meet in person, those conditions would automatically kick in. And some of the issues that we're having, we've been in this long enough that we are starting to see the claims cycle closing, and patient expectations, if they watch cable news, is that they're not going to have any out of pocket. Nobody's going to have to pay for anything related to COVID, and what exactly is related to COVID. And our insurance companies keeping faith with that. We know that insurance companies are continuing to make their enrollees or the beneficiaries meet their deductible. So people are not expecting to get a bill, but they do because they haven't met their deductible. Our receipt of the CARES funding, one of the mandates under that is that patients do not get balance billed, which is nothing but a pass to the insurance companies to not pay anything. So there's a lot that needs to be sorted out at the state level and the federal level. So I guess I'm just teeing up the idea that advocacy this fall for rural and for healthcare may be as critical as it's ever been. So, and I'm happy to answer any questions, and particularly if you have any questions about the medical director's contract. And Dr. Martin, have you had a chance to talk with the local facility?
I have.
Okay.
So they're aware of our intent. And They have some corporate resources. Ed Marash, the executive director, would prefer to partner with a local physician if he's able to. You know, what we're basically doing is reverting to business as usual pre-2016, where the medical director at Royal Vista was one of our physicians, and the medical director at Prestige was a CHCW physician. And that's not an unusual arrangement in the industry to contract with somebody that they come in a half day or a day a week and do administrative work. It's worth calling out that part of the motivation for that contract was that Prestige had indicated that they really were excited about partnering with us in creating or implementing newer models of care for our aging population in this county. And since then, they've lost that enthusiasm and that resolve. And so a lot of our reason for providing that service to them, they've backed away from.
Thank you. Any questions for me? Okay, thank you.
Julie. Dr. Martin. Medical staff.
You have my report. We are starting to look at getting projects back online, figuring out what a lot of this work looks like in the new normal. Some of the opportunities Julie alluded to have less to do with COVID than with economic circumstances that existed pre-COVID. And that's creating an opportunity for us to explore neurology and vascular surgery. And additionally, inspired by COVID, one of the reasons that we send people out of our emergency room is our lack of dialysis capacity. And is that a service that it makes sense for us to have access to for the inpatients? And how many patients that we had sent historically to Memorial or to Regional would we be able to keep if we were able to roll that out? Also, as we're talking with pediatricians, we're looking at what is the need in our population to be able to handle fairly routine pediatric admissions, things like status asthmaticus, which is typically a 24 to 36 hour stay and not medically horribly complicated, but does need monitoring and hospitalization. We're also starting to rejuvenate some of the other initiatives that we had going before this got sideways. You've heard about our partnerships around continuum housing and long-term care campuses. You heard earlier the impact on some of our home health quality metrics, because we have patients on home health that we don't expect to improve, but they need care. And the quality metrics are set up the way they are because CMS expects that the reason people go on to home health is because they are expected to improve. And it really calls out the need for a palliative care service in the county. So we're exploring that. I've mentioned peds, I mentioned neurology. Those are probably the two that I'm the most excited about. We are looking to build up our primary care workforce. I don't know if it's been mentioned in this forum, but Family Compass Care has contracted further to 3 providers, which is just going to create more opportunity for us to provide more primary care in the community. And that's always been a shortage. So I'm back in the mode I was in 2 years ago of I'll take any of the 3 primary care specialties, and if they're a good fit, we want them. And we are interviewing family docs, pediatricians, and internists in addition to specialists. And with that, I'll take any questions.
Lots going on, for sure.
Oh, no, it's just another day at the office.
Any other questions from the board? Thank you, Dr.
And I
Martin.
guess the other thing I'll say that's been kind of a bright spot in my day is that starting at the beginning of this month, for the first time since March, I started seeing patients in the clinic again, which at least gives me hope of light at the end of the tunnel and a return to something resembling normalcy.
Yep. Thank you. Finance, CFO, Scott?
Well, you've got my report on pages, or narrative on pages 28 and 29. And on the second bullet, I mentioned that our revenue was about $5.1 million short of budget, and but actually a little better than I had led you to believe when we were meeting in the prior month. The fourth bullet talks about the receipt of the first wave of CARES funds. We received about $1.5 million in April, and that is the story of why we had, from a net perspective, an operating income perspective, a better month in the month of April than we had in the month of March. I did mention a few of the bright spots that we had with our days in accounts receivable. Were decreased by 3 days, but almost $4.4 million in gross. Our days cash on hand, we had a great great month of collections from the revenue cycle. Excluding the CARES funds, we pulled in $8.2 million. I think that's the first time we've broken $8 million from just a patient and a grant cash perspective. So it was a very, very good month. And with the CARES money, it was $9.7 million of total cash coming in. With that cash coming in, our days cash on hand increased by over 10 days to 134 days cash on hand. So we ended the month in a pretty good position. I don't want to talk about stats on page 31. They're other than swing bed, just about everything there was a negative stat attached with just about everything. So unless somebody wants to talk about that. Okay, good. Page 32, you can see the accounts receivable decrease of 3 days. You can see on the lower left-hand graph an increase in the days cash on hand. Our payer mix, it had been, this is a year-to-date number, but continues to, we were at over 35% commercial last month. We backtracked a little bit to 34.38% commercial, but things are bouncing all over the place right now. And so it still feels like we have a very, very good trend with increases of commercial, and then pretty good handle on the amount of self-pay that is coming in the door. On page 33, you see the P&L, and where we had an operating income or operating loss of $576,000, almost $577,000, and the year to date that puts us at $1.1 million operating loss, and a negative variance of year to date of $2.1 million. Questions about the statement of revenue and expenses? Okay.
Yes, Scott.
Yes.
Why is the revenue down? I don't understand.
Oh.
No, wait, you don't have to answer that. I think I got it. I read
We
something.
will need to go through that stats report line by line, Scott.
It's all right. I think I got it. I heard something about a pandemic or something. Anyway, all right, no problem.
Okay, thank you. And then I think our balance sheet continues to be this the strength of the organization right now on page 34, and just the cash and cash equivalents and investments are very, very solid, and just it's in these challenging times. Right now, it's good to be Kittitas Valley Healthcare. We're fortunate to be have the strength that we do have right now. The foundation, or not the foundation, but Mitchell's report about grants is here. He has applied for a telemedicine grant. He has not heard back whether or not we have received that, but we are hopeful. We seem to meet the criteria. There's the grant opportunities right now are a little slim right now. I was on a webinar today and they talked about a pivot of funds available. And previously, there was a lot of funds available for substance abuse, mental health, and that medication-assisted therapy to help individuals that are addicted. And what I heard today is there's going to be COVID-related philanthropy and funds available. So we're in a bit taking advantage of opportunities that are available, but there will probably be a pivot of the type of grant applications that Mitchell works on in the near future. And then I think that I wanted to comment about Dr. Hershey, and he is going to retire. And Cindy Kelly went over and reviewed his medical records, and we've basically have an informal agreement to take on his medical records, where there's an obligation that a retiring physician has is to make his medical records available for the next 10 years or more. And KVH is going to take possession of those records and maintain them, and provide access to patients who may want a copy of their records. So as a service to the patients of the community, and to help Dr. Hershey, and as he closes his practice, we will help in that way. And so we've got that agreement. That it's not a formal agreement right now, but we have an informal agreement to do that. Questions related to that? Okay. The other question, or I guess the other item that we had, is I did send out, I think we sent out a weekly financial forecast. I think Mandy's put that up on your screen, and you can see this is the trend that we have. I think we've got a piece of it cut off. I shared this with Bob and Bob and John at the Finance Committee meeting, and you can see the positive trends that we have with growth of revenue. This growth in revenue that we are seeing is we're getting back to what our normal was. And this is largely due to the elective surgeries that we're able to start to perform. And we still have variances in the number of visits that are coming to our clinics, and the number of patients that are coming to the emergency department. So, but we're starting to get back to a bit of normal right now. And I've looked, just want to make a comment about what May revenue is looking like. As you recall, from April, we had a $5.1 million shortfall. The May shortfall right now is looking like a $1 million revenue shortfall, a range of about $1 million revenue shortfall to maybe a $1.5 million shortfall. But with the receipt of the CARES, $4.6 million of CARES funds, we our overall cash projections right now are going to, including the CARES money, is going to be over $10 million in total receipts. Our patient cash, as we've had the weak revenue months in May, March, and April, our patient receipts have started to dip as we expected. But with the CARES money, we are continue to be in a pretty strong cash position. And at the Finance Committee meeting, there was we talked about a discussion about the need for some infusion pumps and need to act on that. And so we are bringing a capital request to the board for some 60 Spectrum infusion pumps at a cost for the pumps of $160,000. The overall budget for these pumps was $400,000, and there's an additional Cerner interface cost that to make these pumps operate in a smart fashion will be $214,000. But the only request at this point right now is for the pumps at a purchase cost of $160,000. And perhaps Vicki may want to say something, or John or Bob about the
Yeah, I have a quick question.
You bet.
Here it says Spectrum. We talked about Baxter pumps. Are those two different things, or what am I not understanding here?
No, it's the Baxter Spectrum IQ infusion pumps. These are Baxter.
Okay, great. Thanks for the clarification.
And John, do you want to talk about a little bit about our kind of holding off on the Cerner interface for now and kind of the thought process?
Sure, yeah, no problem. So when we talked about this as a whole, it was approximately $150,000 for the actual equipment. And then we were looking at approximately a $200,000 fee to integrate it with the Cerner system, along with a $2,800 a month ongoing fee to keep that going. We felt the pumps are clearly needed. They're replacing pumps. It's my understanding, approximately 15 years old. It's been on the radar for a while. We need them. You know, they'll be used as part of the process. So let's move forward with that, because that will save us a little bit of money. We also felt the integration is a little more questionable, because at this point, they've not successfully integrated this pump with Cerner, and there either more research or more testing or more development needs to be done. So we felt there wasn't the franticness to authorize that other big charge, and that as the board members, we should talk about that extra $200,000 plus the ongoing $2,800 a month fee and determine if that really is the best way to go. And I talked with Terry during our one-on-one with Julie, because he has some experience with these pumps, and I think I could hand it over to him now to kind of express his own concern about the integration challenges. So we just wanted to break it into two parts. Let's acknowledge we need the physical pumps, and we recommend moving forward with those purchases or the negotiation for that immediately. And the other part, let's continue to discuss it to the point where the five of us at least have a feeling if it's a good expenditure or worthwhile expenditure for the integration. So that's my thoughts.
So this is Terry. I previously actually managed 400 of these pumps. They are a smart pump. On a scale of 1 to 10, the pump itself is a 10. It has a built-in software library. The nurse comes in, chooses the drug that she wants to infuse. The pump has limits on high and low. If she tries to infuse the infusion too fast, the pump will complain. If she tries to do it too low, it'll complain. So it's a really good deal. There are, since I haven't seen the whole thing and stuff, there are other issues. This library has to be maintained by an individual. That was my responsibility. We did an updating through a Wi-Fi, so there may be needs to we may have to look at our Wi-Fi area so that we can update it. We've got to make sure that there isn't any dead spots. When they turn the pump on, it immediately checks to see if there's a new library, and it will update itself so they stay continuous. You also build in different areas, so you could have a pediatric area, you have a ICU area, you have an area that would be in surgery, and they would have drugs that would just be in those areas, so it'd be very specific, so a nurse wouldn't unlikely pick the wrong thing. We also had at the facility, if this pump left the building, we actually kind of had an idea of where it was last seen, and that it went out that door on the east side of the building, which kind of helped us sometimes figure out what happened to a pump if it disappeared. The integration with a medical record, on a scale of 1 to 10, I make it about a 3 or 4. I was actually looking into integrating this with a Cerner when I was working with them. I also was looking at integrating it with Epic, and neither one of those actually integrate too well because they haven't really done a lot with that. What you're talking about when you integrate a pump is you're actually, when the physician writes an order for the infusion, it will send it to the pump, and then the nurse can just verify it on the pump. It gets a little weird that way, and it also does some documentation every time she touches it. It moves it and puts it back into the medical record, so all those things are in the medical record. Now, since we're a group Cerner project, that makes us a little more difficult to integrate this because we're not all by ourselves too. I would assume that was going to be some problem. The other thing, there's a lot of interesting information that you get from these pumps, even though they're not integrated on the medical record. If you get a nurse, if you get staff that are constantly over programming a certain drug, that actually gets sent back to the at that point I was kind of the medication safety officer. I would see those and be able to review those and then go out and talk to the nursing staff and see what kind of issues that they were having with the pump. So these pumps are really going to increase the safety of our patients in the organization, and it will help them be able to do a lot of things. So I totally agree, support getting these pumps in the organization. This is going to be a wonderful thing. Like I said, I used to manage about 400 of them, and that sounds like a crazy thing, but managing it was quite easily because you have an inventory out there that you manage it with software, and it's updated through the Wi-Fi. They also can be updated individually using kind of an infrared thing, and that is something that you aren't going to really do, because one of these pumps goes over and hides in a room someplace for a while, and then it gets pulled out. You're going to want to make sure that gets updated when it gets turned back on again, and it pulls down the new library. So I totally support this. And then down the road, we can possibly look into the integration, but it's going to take a while to build this library. It's going to take a while for us to kind of work out the bugs in the library because there's a lot of different things that you can't really. They were able to kind of give us a starter library, but based upon the products that we use in the organization, you kind of have to tweak it for your own thing. There's, you know, since we're not an infusion thing, we don't do like chemotherapy and stuff like that, a lot of those drugs won't fit in there. And every time a new infusion product comes into the organization, it needs to go through the Pharmacy and Therapeutics Committee. They need to work out an infusion protocol that will be uploaded built into the library and uploaded into it. So this is a really good purchase. The Abbott pumps that we currently have, they function because you can put an IV on it and they put it into the patient, but there isn't any safety software in that. Back when I was working at the hospital, I always wanted to see these pumps upgraded like this because they were just starting to come out, and now they've become so much better. So this is going to be a huge safety issue. Unfortunately, it's probably going to increase another template in our dashboard because we'll be able to monitor our IV infusions, and if there's issues with that, that'll be something that we might want to look at down the road. My goal with any of these things is that you want to monitor it quickly, so that way if you're going to fail, that you understand you're failing quickly, so that way you can fix it and move it forward again with it better. So does anybody have any questions that I might be able to clarify about these pumps? Because I would like to see a unanimous decision on buying these pumps.
That's good feedback, Terry. I'd like to hear from Vicki, see if she had any comments also. Vicki there?
Okay, so I think I'm unmuted. I think, yeah, we had kind of talked about this at finance, and we've been looking at these pumps for over 2 years. I think they've just kind of been evaluated by the nursing staff. We had a team. We had 4 vendors come in and have a vendor fair of 4 different pumps. We came down to Baxter, and then the current new model of our current pumps. The staff were unanimous about Baxter. And more excited too about the integration, but they well understand the challenges we have with integrating with Cerner, and the fact that they're just not ready to do that yet. The pumps alone will speak volumes for our patients and our nursing staff, and they've waited a long time for this.
Okay, so you think they'd be okay with, we're not looking at maybe at a different time the interface? Yeah.
Correct.
Okay.
No, I think they'll certainly understand, and will understand that it's better to wait and get something that's going to work rather than to get something that's going to take years or even longer than that to fine tune.
Yeah.
And it'll take us a while just to get used to these pumps too, and that's a huge learning curve too. So I don't think this is going to cause too much rift from their perspective.
Okay, thank you. So any other comments from the board?
No, this is Matt. I move to approve.
Okay, so we have a motion from Matt.
Second.
A second from, who was that?
Erica.
Erica, okay. To order.
You weren't sure which woman on the board?
No, I just heard just. Sorry.
That's all right.
To order, let's see, medical surgical ER, FPB, and pharmacy pumps, infusion pumps. All in favor, say aye.
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 And then I should amend that with not looking at the Cerner interface at this time. Are you okay with that?
Yeah, that sounds good to me.
Yeah, okay. So all in favor say aye.
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 Any opposed? The motion's unanimous.
Yay,
Thanks.
it's
Thank you,
unanimous.
Terry. Yeah.
Great, thank you very much.
Thank you.
And then Scott, you have one more, you had a resolution?
I do. This resolution, and there's 2 parts to it. It's a resolution 20-03 relates to small works, and one of the outcomes of our recent state audit by the state auditors was that they identified that we weren't as compliant with the requirements of the small works roster and annually approving that small works roster. We didn't have documentation that it had been brought to the Board of Commissioners and approved by the Board of Commissioners. So this is this resolution is is made to get us compliance with what the state auditor's understanding of what we need to be doing is. And so the small works roster means it's essentially, it's a list of vendors that the hospital or the district is able to use that and not go through the formal bidding process, as long as the estimated value of the work that is to be performed does not exceed $350,000. So it allows us to be more efficient in how we get work done by outside contractors. And then there's a list of the small works vendors that would be covered by this resolution. And we're going to use we have a similar resolution for District 2, and we're trying to use the same list of vendors, both Ellensburg vendors and Upper County vendors, so that work done up at the Cle Elum Clinic or the Cle Elum Urgent Care or the fire or the ambulance garage, we're able to use Upper County vendors, and so that's the purpose of this resolution and that list.
And Scott, we do this annually? Is that how often?
As we understand it, it needs to be done annually, and this will be a formal record of that occurring.
Okay, thank you.
And Scott, just to be clear, are we starting with a list that already exists, or are we going to start by advertising and creating the list for the first year?
We are actually a bit of both. We have a list that has already existed that we have solicited vendors, and there are some of the new Upper County vendors are being solicited and added to the list. So it's mostly a list of vendors that already exist, but it's being in the process of being modified to include some Upper County vendors as well.
I just am concerned that to be legal, we have to publish in the newspaper this available opportunity and let vendors submit to start. I don't know that we can start with a predetermined list unless we've advertised to the public to keep it legal. That's my one concern. But I'm not a lawyer.
This is Terry. I kind of had a question about the $350,000 maximum. And, and after that on the paper there, it says breaking a project into different units would be prohibited. A lot of times when we do things in this organization, we will do something and then a few months later we'll do something else that might add to it. At what point is that considered a breaking the project up into pieces, or when is it just one project, and then how do we determine that it's a real one project so we aren't going to get ourselves in trouble?
I think, Terry, as I understand it, it's your intent and what you're doing. If you're willfully trying to work around it, that would be a violation of the law. But if, for instance, the lab project that at some point in the future we're going to be bringing, there will be it will likely be a fairly large project that will be greater than this amount. So we will go through a formal bidding process to have that work done. we have, we have used one of the vendors on the list. VK Powell is the vendor that actually, the construction company that did most of the, was the prime contractor for the Medical Arts Center renovation that occurred. They have also helped us for some of the work that we have been doing related to COVID. They put up the tunnel that, they put up the temporary walls within the hospital to segregate patients that COVID positive patients from other patients, and they've done some work on the stairwell, and so when it's all said and done, we at the end of the year we may have used a VK Powell for a number of different projects, but we didn't have an intent ever to bypass the public bidding process. We're just using as necessary work comes available. I'm not sure how. And I would just one comment about Mandy brought in about we have published, John, an ad in the Daily Record. We publish it annually in January, and also send out letters via email. And so this is,
historically, we've had a process for establishing a small works roster. What got upended was with the auditors this past year, saying that it had to be done by resolution. And so we have had a small works roster in the past. And to Matt's point earlier, just to perfect this, yes, it will be done every January as part of the first of the year business going forward, just to make sure we never find ourselves in this gray area again.
Okay, I just have one other question about that maximum. So if it's all about intent, so let's say we have a project and we figure it's going to be underneath that amount, and then you know how some projects run over budget, something comes up and you find out even though it goes over budget, we still wouldn't be in trouble with that because the intent would be under budget?
I think that would be the case, but Julie, can you help with that? I don't know the answer.
Yeah, I think what they're trying to avoid is, say Ron were to say, I'll just manage this project internally, and he went out and he hired a plumber for $100,000, an electrician for $150,000, and an architect for $300,000, and what we knew was $1 million project, and we just individually bid it all out. I think that's what they're trying to avoid. The $350,000 it comes from statute. So I agree with Scott. This is about intent. So if we have a $2 million project, our intent is to take it to bid. So.
Okay. All right. Well, great. Thank you for the clarification.
So Scott, on the list itself, there's some that are in yellow and some that are in red. Does that mean anything?
I'm not sure.
Okay.
No, I don't think it did, Scott. This is Rhonda. I think they were using that somehow in engineering, but it didn't have any meaning for the rest of us.
Okay.
Probably I think Ron said it should have been removed before he sent the document.
Okay. All right. Yeah, no problem. So we have
let me ask you a quick question here, just so I understand. On the sheet that's up right now, for example, under asphalt, there's 2 companies listed. How do we know which of the 2 get the job without bidding? I mean, is it a quick verbal bid between the 2 companies and we pick the lowest of that? It's just not a formal bid, or what can you enlighten me there?
This gives Ron the opportunity to call one that's more readily available, or one that he's working with on another project, and say, so it gives us the flexibility to pick.
Okay, thank you.
Mm-hmm.
Any other Questions? So we have resolution number 20-03, small works roster. Do you have a motion to accept that
Move
resolution?
to accept the resolution so that we can do it correctly going forward.
I'll second that.
Go for it, Matt.
And Matt seconded. All in favor, say aye.
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 Any opposed? All right, it's unanimous.
Yeah, John and I attended that audit meeting, and so I knew that you guys would fix this, but it's good to see you guys moving forward with this. So
Yeah, agreed. Thank you.
We're not done with that yet. I think Scott has determined that we need to formally have KDA bid to remain the architect of record, and he's working on getting that to you next month.
Sounds good.
Thank you.
Thanks, Scott. So we have operations report, patient care services.
Yeah, this is Vicki. Can you hear me?
Yes.
Perfect. Okay. My report is there. I'll start on page 44. I'm not going to go through everything. I just do want to say that it's kind of been a little struggle getting back to what our normal is. We've been COVIDing for a couple months. So we are trying to get some of our projects back on our boards and resume where we were. One of those will be our telemetry accreditation program. OB is doing a lot of work there in their department as well. So I'll be happy to take any questions if you have any.
So rough, just a quick question on the students coming. How many do we have?
Yeah. So YVC has, I believe, 9 students, and they have 8 students, and they'll be here for 9 days. And then Heritage Nursing School has 3 students, and they'll be here for a total of, I believe, 7 days.
Okay, great.
So they're just finishing up their clinicals. They weren't, unfortunately, the only hospitals they can go to that have really opened up is Toppenish, Sunnyside, and us. So they're trying to finish up their academic year this year.
Okay, awesome.
Yeah.
Any questions for Vicki? Thank you, Vicki.
All right, thank you. You're welcome.
Ancillary services, Rhonda?
Hi, everyone. I do have some updates for you. I wanted to start really talking about testing in the laboratory and let you know that we have about 3,000 kits right now for testing for COVID-19. So we're well situated for testing our community, not the whole community, but those that need it. We're also looking at what we can do for on-site testing. We know how important this is for our patients, and in particular, patients admitted to the hospital or our pre-op patients. So we've been looking at what we can do to get it on site. And of course, the manufacturers of this equipment want to sell their equipment to people that they are currently a vendor for. So that lets us out of the market for a lot of the things that you hear on the national news every night. They make it sound like you can just get testing easily, but it doesn't work like that. Our biggest hope is with our BioFire equipment, and we do have a cassette available to us now that will do all of our influenza testing, the RSV testing, and also COVID-19. So we're in the process of doing validation studies with that. The problem is it will be limited to probably 60 tests per month. So we will really have to prioritize what patients we use that for. And hopefully by the time fall hits and we have a surge again and influenza happening, we'll be able to get more testing on that piece of equipment than what we will have probably available to us next week. The second piece that we're looking at is sending maybe some specimens to Insight. And if you recall, Dr. Sandquist is our medical director and affiliated with Insight. So they do have COVID-19 testing available They think they can get us a turnaround time of 2 days, which is fantastic for our pre-op patients. It does cost $100 more than what it does through LabCorp. So we're in the process of building that order and a charge to go with it, which is definitely a backup for us if it comes down to the wire, like it has a couple of times when we've had these pre-op patients that are coming in that day and we're just now getting their lab results.
Rhonda, I'll just add to that Virginia Mason Memorial is facing the same issue, and they're being limited to 120 tests a month.
Okay. Yeah, it's across the United States, the testing is so limited. And we've had, as Julie mentioned, patients from UW being sent to us to do pre-op testing. And we've pretty much said if they're a Kittitas County resident, yes, we will do that. And also we had some cancer patients that were coming from Yakima, and we did between 6 and 10 in our COVID clinic, so that they had been waiting a very long time for a procedure. So we did their pre-op testing for them so they could go ahead and get that procedure. But typically we're not allowing that from other hospitals. The second is on the antibody testing. There's, lots of communication going around about that. And I did put in your supplement packet tonight, I think Mandy sent out an email about the antibody testing and some handouts that we've developed. A couple of them are specifically for patients and then a couple for providers. And we were developing these because Dr. Larson was wanting to start doing some antibody testing. He was requesting this prior to the Twin City Foods outbreak. And then I think we've been a little preoccupied with that. But I expect that's going to come back around where we're going to want to be doing more antibody testing. And we wanted to make sure that our providers knew that the antibody testing doesn't take the place of the COVID-19 nasal swab test. So if you are doing a diagnostic test, wanting to see if you have a current infection, you need to do the nasal swab. If you're looking for antibodies, then you would do the blood test, and that's for the IgG antibodies. And it doesn't really tell you how long you may be immune. It doesn't even tell you if you are immune. It just tells you that you have been exposed and you are developing antibodies. So there's definitely a lot of development going on with that, not just with the IgG, but with some of the other Ig antibodies as well. So that's coming. Any questions there?
So Rhonda, all this information on news about 50% accuracy rate is not true on these antibody tests?
Well, I think it depends on what test you're using. And so the information that I put together is exactly what UW is handing out. And we are using the same, we are using LabCorp's instrument, which is exactly the same instrument that UW is using. So that's where that information came for the sensitivity and the specificity, which is really quite high, meaning that it's a pretty accurate test, or that's what they're touting to this point. I think some of the unknowns come around. They're still developing and working on the IgM antibody, and I think that's coming, but I couldn't find any literature anywhere on that that talked about it or that was available to the general public at this point.
Okay.
And there's a wrinkle in it that points out kind of the subtleties that go into this. The test that UW is touting, they're claiming 90% specificity, which means 10% false positives. False positives are not a function of the number of positive results, they're a function of the number of tests. And if you're running a 10% false positive, you test 1,000 people, you've got 10 positives without any illness. So if we were to take a test with a 10% false positive rate and test everybody in the county, we've got 4,700 positives without disease. And if we come back with 5,500 positive test results, we have no way to know how to interpret that. So the test is good, but it needs to be better. And Dr. Larson has made the comment that it's useful from a population health standpoint in terms of knowing.
Karen was freaking out because she passed a expedition or something like that, driving out of her driveway with a woman and a small child in it. She wanted to know whether somebody, and she had no idea who they were, or whether they were somebody visiting you.
But when he was asked by a patient if the patient should spend money to have the test done, he advised that the patient would do
Just
more good by ordering takeout.
Hey, Terry, we can hear you.
Oh.
Anything else about antibody testing?
No, thank you, Rhonda.
Okay. I wanted to let you know also under diagnostic services that we found out a few weeks ago that our former radiology group, MDIG, that is bankrupt, has turned over their accounts, which are KVH accounts, to another agency for collections. And their bills look like a debt collection bill. And it's the first time that the patient would have received any type of an invoice for payment. So we've had probably a half dozen or more calls and concerns into our billing department wanting to know what's going on. So I've reached out to them to try to get a list of patients. I would love to have their names so that we could be proactive and contact them and say, here's what happened. This isn't, you know, a collection agency. It is your invoice, and explain what happened. And if not the actual names, at least kind of have a general number of the outstanding claims that they have. So I just wanted you to be aware of that in case you hear any comments from the community or any complaints. But usually when you talk to the patient and explain to them that this is a company that has gone bankrupt and they've turned over the accounts, they've been fairly understanding of what's happening.
Okay.
Can I just make it clear, these are KVH patients, but they're not our bills. They're not KVH accounts. We've already collected on the facility piece of it. So it's unfortunate.
Correct.
Yeah.
Yeah, unfortunate. And then if you're looking at the comments under 340B, and John, I know probably is interested in this since he's on the compliance committee and had questions and lots of positive comments. We have really looked at a way that we can rebuild our file that we're sending so that the file that contains the patient demographics and the prescription information can also contain that financial class. And it looks like that's going to be a fairly easy thing to do. So that's sort of where we are right now as far as taking care of the problem that we identified on those claims. And we will have to obviously run a report going back to say, here's the number of claims that we billed for 340B that we shouldn't have. And in this particular case, it's not finances, but it's the medication credit to our pharmacy. So we would actually be reflected in our pharmacy drug spend.
Okay.
Any questions about that, John? Is that clear?
Yeah, no, thank you. That's great to hear.
Okay. And also along the lines of pharmacy, I wanted to let you know that Washington State does have remdesivir, and that is the experimental medication that is being used to treat COVID-19. In, let's see, May 11th, the state received 800 vials of that medication, and that was distributed to hospitals that had a high incidence of COVID-19 hospitalized patients that might benefit from it. We have received a second shipment in the state, and that shipment was for an additional, I believe, 1,640 vials. So quite a bit of medication coming in for us to utilize. We actually didn't throw our hat in the ring to get some because we haven't had any hospitalized patients that might need it. But unfortunately, yesterday, we did have a patient that was transferred to us from Yakima and may have benefited from that particular medication. So we are in the process of obtaining that in our pharmacy. And we have been able to receive just a lot of guidelines from the state and from the manufacturer for our providers and for our patients, as far as information sheets about the medication, how to obtain informed consent on an experimental drug, and then just dosing guidelines and things like that. So we've distributed that today. Like I said, the patient ended up today not needing that medication, but we did go ahead and put a request into the Department of Health to keep some stock on hand that might be able to treat up to 3 patients.
Great.
Yeah. An update on Huxville District 2 that I didn't put in my note, probably should have, is that in April, we were sent a request from an organization that is doing a supplemental impact statement for the development called 47 Degrees North. It was formerly known as Bullfrog Flats up in Cleellum, and they were anticipating building hundreds of home sites, and now they have sort of changed their plan. And the way that that might impact us is they're looking at now having 647 RV sites up here instead of just homes. So I was able to do a response to them, really kind of outlining how that might impact our tax base in Upper County, and how that could impact the EMS service that we provide, especially with people coming in and out. If you have that many people coming into an RV site on I-90 in and out of the community, anticipating a lot more accidents, that could really have a negative impact. So I just wanted you to be aware that we had sent that off.
So Ron, is that the same group that is supposed to build like almost 1,000 affordable houses up?
Yes.
Up, and now it's RVs.
Well, they still have some home sites there,
okay.
but I know it was, closer to 1,000 home sites, and they switched to 647 RV sites, and then the rest home sites.
Wow.
So they did a lot of changing in their overall plan.
Yeah.
Yeah, quite a bit. So the community here was pretty alarmed about that.
Yeah, for sure.
Yeah. And then finally, I think Mandy sent out also in your supplemental packet tonight was a floor plan of the work that we've been doing, looking at expanding the lab. So did you receive that? Yeah, there it is. And that's the view she has on the screen now shows the entire hospital and where the lab is located in it. And we're looking at expanding into the pre-op services area. So it would give us a lot more capacity than we have right now. And we're looking at having everything be on a very modular design. So the workstations are on wheels. We can move things around as much as possible, depending on how our workflow is. And it has a lot of visualization across the work areas from one station to the other. So it's been kind of fun to get back together with the staff and get going on some plans that don't include COVID-19.
Hey, Rhonda, using the mouse, can you show me where you're talking about expanding?
Can I do that? Right, if you just draw a line directly across, you can see, yeah, there it is. That's our current lab right here. So we would be expanding upward towards the medical outpatient, surgical outpatient area. That's the new area.
Okay.
So this is what it would look like after the change. Is that correct?
That's correct. Yeah. And so we had originally been planning to sort of do this in a phase where we would remodel the new portion first and then come back and remodel the old. But in talking with Julie, she was trying to get us to think that maybe it might be more beneficial to just move the lab and do it as one fell swoop. So we are potentially looking at maybe using the conference room upstairs as a temporary lab location. And then if we needed to, having some services be over in the FME lab, the old FME lab as well. And then just trying to come in and remodel the lab as quickly as possible. that it might be less expensive and be completed faster.
So, and then where would surgical outpatient go as far as their screening room where they weigh people and stuff like that? That gonna go back?
So the pre-op area, we have lots of opportunities for that on our campus. I didn't mean to interrupt you, Julie, if you were getting ready to talk. I think we would ideally like to have those services located close to our surgeons, our orthopedic surgeons, general surgeons, have them over in that area, real close for the patients.
So the old pediatric clinic or SANS clinic space, so that when you leave with your scheduled time from orthopedics, you could stop at Suite C on your way out and schedule your pre-op. That's part of the thinking. One of the reasons we're talking about, typically we, as Rhonda has mentioned, we would phase this project, which about doubles the length of the project time. And one of the things we're concerned about is we know this COVID thing is not going away anytime soon, and we've committed to being able to surge and be responsive. So this is a priority project. You guys have all gimbed and toured the lab, and you know how cramped it is. I also think lab being in the center of the hospital where it is right now is optimal. It's accessible to outpatients, to the ED, to med surge, everyone. But we want to get in and we want to get out and get that completed so it doesn't interfere with our ability to surge and deal with the community the way we're having to now. So this will be an exercise in, you know, I think Mandy Weed and I get thrown out of our space. The ABC conference room conceivably could be taken over as they temporarily move all those lab services out of the lab so that the contractor can get in, get done, and we can get the lab back to working in their normal space, their new space.
Julie, how long do you think that retrofit would take if you move them upstairs temporarily? Is it, you're talking weeks or months or?
Ron's just starting to work on that. Rhonda, do you know if he got any firm answers from?
No, he's just had a general walkthrough with the contractors at this point to say, is this even feasible to put it upstairs? And I think he feels very much that it is, but we haven't gotten much beyond that.
So what about the old FME building? Is that something just too much to try to? Yeah,
it's you know, the lab there isn't very big, so we could, you know, have our chemistry analyzer, a few instruments there, but the layout just doesn't lend itself to lab at all, and we would have to do so much remodel that it wouldn't be effective.
Yeah, okay.
I think this, frankly, and I don't mean to make light of this, I think this is a great exercise in thinking outside the box and being a little flexible. So I think it'll challenge us to think about how we manage these projects going forward. So.
Okay, thank you. So, and Rhonda, one more quick question about the athletic trainer with the Ellensburg School. So this is the first time. I mean, in the past, I think the athletic trainer has been an intern from CW, but we're actually hiring a trainer to help out the high school kids.
That's correct, yeah. And to really kind of help work with our orthopedic program and our physical therapy departments so that, you know, we have a really strong presence with the schools. We hired Zane Davies, and he went to school at CWU and has also lived in Ellensburg, so he knows the community really well, and we're pretty excited to bring him on.
That's really cool, and I think it's important that we somehow the community knows that, because I can see that getting buried of, hey, the Ellensburg School District provides a trainer, and because a lot of kids use the trainers at the high school.
We'll make him wear a KVH shirt every day.
Yeah, right. Everything is our color.
That's his uniform, the KVH polo.
Yes.
This is part of that broader program we're trying to really connecting the dots. So
it's huge. It'll pay off. It'll pay dividends
Yeah,
for sure.
and he's super excited to go into other school districts too and do some
Yep.
teaching, like up in Clallam Roslyn about concussions, go to
Yep.
KVH. He really is excited about being out there. So I think
Yeah.
we got the right
Oh.
person. It was worth the wait.
Yeah.
Next stop, CWU. So,
Yeah.
Thanks, Rhonda. Any other questions for Rhonda?
This is Terry. I just had a quick question. My sound kind of messed up a little bit. When you move the lab upstairs, is 100% of the lab going up there, or just a little bit of it?
As much as possible. We may have to take some over to the old FME building, but we're going to try to get as much as possible up there.
Okay, good.
That'll be best for patient care.
Yeah, because when we did a remodel in the pharmacy when I was there, that was before the administration offices were there. That was just an empty hole, and we moved the pharmacy up there when we did a remodel in the pharmacy, and we were up there for almost 2 months.
Oh yeah.
And yeah, so I just know that it could be a potential big thing because we had to move our IV hoods, and they had to be recertified. I'm not sure if the equipment when it gets moved, whether it has to come in and be recertified or reset up or anything like that. But we were up in that area for a good 2 months or more, and it was just an empty area where the administration office were. It was just bare walls. There wasn't really anything else in there. So
I'm anticipating at least 9 months.
You think they may be out of there for 9 months then, huh?
9 months to a year would be what I would bet.
Okay. All right. Okay. Well, then we'll have a new baby lab, right? After 9 months?
A new baby lab. Yes.
Okay. All right. Thank you.
Thank you.
Appreciate it, Rhonda. So we'll move to Carrie. Clinic operations.
Hello. Yes. So I have my report, and the couple of things that I didn't add on my report is just the direct patient scheduling. It is a new service that we're offering to our patients effective today. So hot off the press. This is where the patient can sign into their patient portal and schedule a direct appointment for their provider. And as of 4:30 this afternoon, we had our first patient go ahead and schedule for tomorrow, and it looks great. So they, and that was unsolicited. So they must have already been in their patient portal poking around and going, oh, look, I can schedule appointments now. So we're really excited about this, particularly at a kind of the atmosphere that we have in our culture right now, our society right now, of it's just kind of a crazy time, and we're really trying to make it super easy for our patients to come back and get the healthcare that they need in the clinic. So we will work with Michelle and get some marketing out on this in probably mid-June. We did run this service through our PFAC, and just to get some feedback. They were incredibly excited to hear that it was coming, and so I'm excited to report back to them that it's live. Then the only other thing I would add to my report is that, let's see, so ear, nose, and throat and allergy they will be going live with pediatrics with Cerner. So that's on the report, but I wanted to just mention about ENT that so far, particularly around the allergy testing, we've already tested over 50 patients. So this is something that, this was sort of an add-on service that we thought, oh, well, she's done this in the past and she thinks this will be great. So the community has responded really well. And this is during the COVID period of time. So this is April until now. It's about 50 patients for allergy testing. People want to get in, they want to figure out what they're allergic to so they can begin their treatment, their allergy treatment shots. So, and that's all I have to add.
Hey, Carrie,
yes.
Did you fill the manager of workplace health position?
I did. Yes, thank you. And I don't know if I can say her name now, but I've violated that rule maybe once before at a board meeting. So, so I'm sorry, Amanda, if I can't say her name, but because here it goes. Her name is Jennifer Mullins, and she comes to us from Olympia. And this is the workplace health clinic manager position that we really have noted that we just need to have a clinic manager focused on this business line. It's so completely different than any other service line we offer. It's more retail than it is the regular clinic, so our traditional clinics. So we're looking for someone who can really connect with our community members, our business members. Again, with COVID, we have noted that workplace health numbers have actually increased and have been busier than ever. A lot of that is due to the fact other service lines locally have closed, and so people are coming to us and signing some contracts. We've got about 6 or 7 new contracts since March.
We've tried to tuck this work into the other clinic managers sort of day before it, but I think this was a really smart move on Carrie's part. As she said, this is retail business. It's a very different thing, and it's an opportunity that we can really get in front of with someone helping to build the business, make sure we're billing correctly and stuff. So I think that'll be a great add.
So that's all I had to add to my report. Is there any questions on my report? Don't see that it's actually up, but maybe that's mine.
Carrie, this is Erica. I have one question for you. I'm super excited to hear that the portal scheduling is live. I think that's excellent. Something I've looked forward to for quite some time. Since it's through the portal, does that mean that it's only available to established patients, at least within the organization? How does that work? Let's say I'm an FME patient, but I want to schedule a PEDS patient for one of my kiddos that has never been seen.
Yes. So yeah, thank you for bringing that up, Erica. That was originally told to us by Cerner that it could only be established patients in order for you to be able to get in. However, we tested it with one of our clinic managers who has not been seen in one of our clinics, but she's actually been seen in the hospital, and she was able to still make an appointment. So we may have found a workaround only because we're enterprise, and meaning that we're all one source, right? So they that might have been a way to kind of sneak in, which brings joy to my heart. We want to, again, make sure that when you're at home and you're thinking about these things at 6, 7, 8 o'clock at night, that you can just log in and you can go ahead and get an appointment. So yeah, she was able to do it, and I'm not sure how or why, but she was, and it's exciting.
Excellent. And then just to be clear, if somebody is, say, new to the area, has never been seen within the organization, they would still need to call or schedule not using the portal?
Correct, because they would never have given us the email address that would have established their opportunity to get a portal account. So they'd have to get into our hospital system somehow. So that is unfortunate.
Still, though, I think that's a huge upgrade to our availability and accessibility. I'm very pleased to hear that.
Good, thank you. Any other questions?
Thank you, Carrie.
Thank you.
Community relations.
Hi,
Michelle?
guys. Yeah. I don't really have a whole lot to add. Carrie and Rhonda, talked about things coming down the pike. You mentioned, the opportunity with the trainer program and Ellen's and EHS, as well as the portal. A lot of what we're doing right now is we're doing a lot of chronicling and interviewing of what's happening with our employees. and our community members through this COVID crisis. We're coming alongside community health. They're getting a lot of pushback on their messaging now, and so where appropriate and how we can stay in our lane and help, we're trying to share the message with them to get the word out to the community on ways to still stay safe and to practice social distancing. And then at the same time, trying to get back in a respectful manner of getting some of the services out there, you know, working with Dr. Azrael and the addiction medicine program, things like that. So we're kind of doing that fine dance between living COVID and trying to come out of COVID. And I'm happy to take any questions or feedback.
Great press on Medical Arts Center this week.
Yeah, it was very nice.
Yeah, good job. Any other questions for Michelle?
Michelle, I talked briefly to Julie about this at our meeting regarding regarding this meeting. Anyway, I was thinking about doing an op-ed on preparations for COVID and things like that, but I think I'm just gonna hang tight since things are changing so quickly right now, and then maybe when things start to settle down, we can kind of look back and see how great we responded, and can kind of get that out there too, and talk about the things we did to prepare, you know, the rejiggering some of the buildings, and so we could handle more patients, and changing the airflow, and, you know, setting up the clinic and things like that for testing.
You know,
yeah, go ahead,
Matt, I appreciate that, but I think there could be an opportunity now to talk about, you know, like Julie mentioned on the forum, we're kind of talking about phase 2, what's changing and what's not changing. And for KVH, there's a lot kind of not changing as far as the PPE, the safety measures, the social distancing, things like that. And pulling it together in a communication to the public, you know, focusing on Kittitas County did this as a county. It wasn't KVH alone. It wasn't public health alone. It was, you know, it was the citizens and everyone working together to get into phase 2. And we need to keep that momentum to keep going to phase 3 and phase 4 and continue to work together in order to make that happen. Okay. I think it could be a strong message.
Well, that sounds good. Why don't you and I can get in touch, because I want to write something that's not academic, and I'm happy to.
You do a good job. Give yourself credit.
Thanks. So I'm happy to put something together like that in conjunction with you, and obviously with some input from Julie on that. So
yeah, sounds great.
Okay, thanks.
Any other questions? I think as we kind of come through this, and we know that we're coming through it, it would be cool to kind of acknowledge how the community did come together, Kittitas County, you know, all the health folks, even maybe during like our annual barbecue or something, kind of putting a, you know, coming out of COVID twist on it or something would be something.
You stole our idea, Bob. We just have to be able to get it. We just have to be able to get to that point that we can have a barbecue.
Yeah, exactly.
How do you eat a pork rib with a mask on?
Anyway, yeah, so I guess there's no education or board reports or old business. Any new business that we need to talk about?
So obviously there's nothing to talk about here, but you know, the WISHA meeting typically held in June was canceled. And I'll be attending tomorrow. There's an AHA meeting, virtual AHA meeting, plus the Committee on Governments, AHA Committee on Governance meeting tomorrow, which had been scheduled for Chicago. That was obviously moved virtually. So, you know, we should just sort of keep an eye on that as things start to change. You know, maybe the WISHA annual meeting in the fall might go virtual. in which case, more of us might be able to attend it. If it's not virtual, if it's in person, then we'll have to make some decisions about that. But anyway, it's just something to sort of keep an eye out for when things start to get rolling again.
Yep, sounds good. Any other comments from anybody? If not, so I guess we'll move into, we'll adjourn this meeting. We'll move into executive session, maybe like a 10-minute break. Does anybody need a break before we go into executive session?
Whatever you want, Bob.
How about a 5-minute break?
So 8:15 will convene.
8:15.
Okay.
Yep.
And I would anticipate that I'm not asking for any action following executive session, but you all should have received some information. I was thinking we could talk about this for 15 minutes or so. Does there seem to be more time needed, or?
That's fine.
I think that's fine.
Okay, perfect.
Great. Thanks, everybody. Thanks for everybody's time and attention and all the good work. I mean, there is so much stuff happening, between all the senior leadership, the community as a whole is coming together, and so many things are happening in a positive way. So it's very much appreciated. Thank you. We'll see you in a few minutes.
Thank you.
Bye. Thank you.